Um, All right, good morning, everyone. We'll wait a couple of minutes while people are coming in from the waiting room. All right, does it look like everyone is here?
For the most part, I
For the
think,
most
I
part,
think we're good.
okay. All right. There's a few more coming in, I see. All right, for the sake of time, we'll go ahead and get started. And if people are joining in late, we'll let them go ahead and join us. I want to start off by introducing myself. My name is Dr. Darren Ramsey. I'm one of the faculty at Butler University, for those of you who I may not had the chance to meet yet. And I will say this is such an exciting time for each of you as you start preparing to go out into the pharmacy workforce and start making a difference and a change in your career. And so I know on behalf of all the faculty at Butler, Purdue, and Manchester, we want to welcome you and congratulate you. And also a big thanks before we get started to IPA for hosting this every year for our graduates. It's a really great opportunity to sort of prepare as you start studying for that big exam that we've hopefully been, as faculty, preparing you for since you started the professional phase. We're going to start off before we dive into sample questions and so forth, going over some helpful tips to think about as you prepare for the Naplex. So I'm going to take a few moments to share my slide set. These were sent out in the link, so hopefully with the agenda. So hopefully you each have access to these. And I'm just going to share some of my helpful tips that I've taken note of along the way or that I've heard from former graduates. This is just an outline of some of the events that we're going to be doing today. We've got what I consider an excellent panel of speakers today. Myself from Butler University, where I'll be covering some of the non-prescription drugs and over-the-counter questions and scenarios that you could potentially see on the Naplex exam. We also have Professor Jane Krause for those of you from Purdue University, you know her quite well. This is a really great section going over pharmaceutical calculations that she's going to cover. And I think this is an area that students sometimes get tripped up on if you're unsure of how to set up a math problem and spending too much time on it. So she's going to go through some helpful tips and brush up some of the skills that maybe you haven't used in quite some time. And then also we have Adjunct Clinical Assistant Professor Janelle Rogers, who will also be joining us to round it out, going over therapeutics, approaches to problem solving, and discussing patient cases. So this is our panel of speakers that you'll be seeing throughout the day. And this is our agenda. We'll kick off again in this order. We do have breaks throughout, so we realize that this can be a long session. Virtual does make it nice because we realize many of our graduates are spread throughout the state and maybe even neighboring states as they're preparing to move and so forth. So having this virtually has been nice because we're able to reach more graduates that might not have been able to come here centrally to Indiana to attend our live event. Okay, I see some chat, so I'm going to take a little break while I've got the agenda pulled up just to see if there's anything that I need to take care of. Okay, some of the students are wanting to know how to access the slides. On the agenda, there should be the links at the end of each one that you click on. And so you may have to do control click to access it. Sometimes you can just click on it and it will work depending on the settings that you have. And so you may have to do control click and it should open up the link within the embedded agenda. Thank you I see some of the students were able to answer that, so thank you. We do also have a built-in lunch break as well. We realize that sometimes virtual meetings can seem long, and so if you need to take a break, feel free to do so, but be sure to jump back in because we don't want you to miss any of the great tips that our speakers have to offer today. Hopefully by now you're familiar with or you've went to NABP's website to look at what is comprised of the Naplex and MPJE. So just a reminder, I have the link in this slide as well that you can go to. If you have not checked that out, I really encourage you to do so before you sign up. The Naplex exam is 225 questions. Usually 200 of those questions are operational questions that are actually count toward the test. There may be 25 pre-test questions that are on the exam. To complete the exam, you're given 6 hours. That's a long time. So you'll want to use your time wisely throughout the exam. There's going to be questions that you come across that are going to be very intuitive, that you're going to feel like you know, and others that you're going to have to spend a little bit more time on. Starting last year, this was pass-fail. So you will, obviously, if you pass, that's great news. In the event, if you were to fail, you'll find out which competency areas that you scored low in that you need to improve upon. Likewise, the MPJE, we won't be covering that today, that's tomorrow, but there are 120 questions, 100 of those are operational questions. There are other 20 pre-test questions that are being tested that will not count toward your score. You will have no idea on either exam which ones those are. And you'll have 2.5 hours to complete that exam, and it is also pass-fail. The format for the Naplex, which is what we're going to specifically focus on today, will have patient profiles that you will refer to, and you'll still be able to see that patient profile with several questions related to that. There could also be interspersed what we call standalone questions where you don't actually need the case to answer those questions. And so that's where it's going to be really beneficial to read the question carefully and find out if you need to dig into the patient profile, or is this a question that you can answer really without needing that patient profile to refer back to. It's almost like navigating through a medical chart, which you all have had a year's worth of experience to do and navigate and find answers to patient questions. I also recognize that it's probably for many of you been over a year since you took an exam in a classroom setting or even on a standardized exam. I know at Butler, our PCOA or PCOA exam was exactly 1 year ago, and our current students are taking that exam starting today. So that might be something to brush up on if you have access to your results of that, to see what areas that maybe you didn't perform as strongly in. I know many schools use ExamSoft and have different features set up for that, and some schools may follow the Naplex design when it comes to this. It is a fixed format exam question type, which means all questions are interspersed throughout and everyone's exam will be very similar. All test questions are to be answered in the order that they are presented. So what does that mean? That means backward navigate, you cannot go backwards. So you can't skip a question and go back to it. And you can't return to a previous question to review your answer. Once you answer the question and confirm it to move on, that's it. So that's why using your time wisely on questions that you're unsure of is going to be key. Sort of go with what your gut instinct tells you is correct, and trying to read too much into it and second guess yourself. So no changing the answer. Once you've confirmed it, you cannot return to any of the previous questions. And this is the competency areas that began with last year's exam. There are now 6 areas, and you can see where the majority of the exam is in area 3, which is the developing or managed treatment plans. So a lot of therapeutics knowledge will be key in this one. And you can also see where calculations fit in area 4. So even though that may be only 14% of the exam, there are several questions related to that. And if you're unsure of how to set up the math, or if it's been a while, that could be an area of struggle for some. And for those students that don't do well, usually it ends up being several of the areas that they don't perform well in, but area 4 is always a big one. Just to preview some of the format of the questions, majority of the questions will be a multiple choice format, similar as you see here. I think most of us are familiar with this type of question format. However, there are several select all that apply questions. Sometimes students don't like these, and I understand why, because you never know if you've selected all of them or not. Now, this isn't going to be on the majority of the exam, but there are several of these. And so we'll use some examples throughout today's sessions to practice looking at these types of questions. One way that you'll know that it is a select all that apply question is if you read the stem at the end where it says select all that apply. So be sure to read that. If it says that, then that's going to be your clue that there is more than likely more than one answer that you need to select. In addition, there are constructed response question formats as well. And a lot of these you may see specifically when it comes to calculations or dosage, and where it will specifically tell you how to round your answer. And so you'll enter that in. And so it will say whether it's one in a numeric, which is what most of them would want this in. So pay very close attention to these and be prepared to answer some of these on your exam as well. Another format that I don't think we will be going over a lot today, but just sort of be aware of that they could be on the exam, is rank order of certain maybe drugs. For example, in this one, it is ranking highest to lowest potency of topical corticosteroids. And so you would have to move the drug over from high to low, but be sure to read the stem carefully because there could be some that wants you to rank low to high. And so that's going to be very key to look out as you're navigating these types of questions. And then finally, there are hotspot questions where you will have to use your cursor to click on a particular object in the photo to show where something may work. A lot of drug action questions or medicinal chemistry could appear this way, or also showing the cycle of how a drug works, as in the case of this. So these are just some examples, and these are all from NABP's website, so you can go back to them if you have trouble accessing them on these slides. The next thing I want to go into is some available resources that are going to help you along the way. And everyone has to find what works specifically for them, and what works for one may not work for another. But I do know that taking tests in a situation such as this can evoke some anxiety, some stress, some fear about whether you're going to pass or not. Obviously, you didn't go through a rigorous professional program for 4 years to come out and not pass. And so as faculty, we want to make sure that you are armed with the tools that you need to be successful. And I think attending today a session such as this is one way to show that you're in this to prepare and study. I know many of us have the greatest of intent to study throughout our P4 year, and hopefully many of you and most of you did do that instead of waiting till the last minute. I also understand how sometimes it's easy to push away because it seems like it's months and months down the road, and then suddenly the day is here to start taking it seriously and prepare. So these are some resources that you can do. On NABP's website, they actually have a pre-Naplex and a pre-MPJE exam. This is something that does cost a fee to take, and you can do this in your home setting, similar to how over the last few years, many of you may have taken the PCOA exam at home. And practice how you do on Naplex type questions. Usually what they do is they take previous years or past questions to use. It doesn't mean they're using them again, but I think this is a great way for you to see. You can take this up to 2 times, I do believe, and but you do have to pay each time with that. And it doesn't do the full amount of questions. You don't get 6 hours either. It's 140 minutes and it's 100 questions. But it will give you a breakdown of how you did, how you performed, and you can use this. I've talked to several graduates that did do this on their own, and they all spoke very highly of it and said it was worth their time and that they were glad they did it. Now, if you are here, I would say, let's see a show of hands of who's heard of RX Prep, and I'm sure everyone has heard of this resource. Oh, I see hands raised right now. Thank you. This is probably the most popular tool that is out there on the market, and I hear many students are using this. I think the resource is very comprehensive. It contains a lot of great math calculations, practice exams, case-based chapters to help you study. I think I asked several current students that I was working with, what they liked specifically about this book, and many were like, the tables are very helpful, the mnemonics are helpful to help you rememberize certain things that you may have forgotten and brush up on skills. So this is one that you'll hear a lot about. I will say this is probably the most expensive option that does exist. And so as you're thinking about maybe asking for a graduation gift from friends or family, if they're willing to pay almost $200, this is an option that you can certainly ask for. Now, many of you can also ask some friends if they have the previous edition. That this is the 2021 here that you can borrow or use if you happen to know friends. And I know that commonly happens. You can find this one in places like on Amazon for a little bit cheaper. But if you look, it's not that much cheaper. I found it for $154. So if you wanted to save about $50, that could be an option. I just want to warn, be careful going too far back, because you almost think of it as like investing in a new car. Do you want a good deal on an older model, or do you want the current model that's more up to date and has all the new stuff with it? So just something to think about as you're looking at resources to study from. If you do happen to go online and check out RX Prep, they also have an online portal where you can buy additional access to their online test bank. I know the book is great because you can travel with that. You can take it with you. It is pretty thick. So realistically, I don't know how realistic it is to get through the entire book, but it is something that if you set dedicated time for maybe those chapters that you want to brush up on or feel less strong in, you can certainly use that as a review. But they also have access online where you can have 6-month, 3-month, and 2-month access. I've got the price points there. Obviously, I will say most students, typically it's encouraged to try to sign up and take the exam within the first 90 days of graduating. NABP sent information to all the schools, and it showed a correlation of the longer time after graduation that students took to take the Naplex, they were more likely to not pass. And now, is that really due to them waiting so long and maybe loss of knowledge in that short period of time? Or is it more likely that students felt less prepared and so delayed to take it, and then at the end they were still not prepared? Who really knows? But there was a correlation that if you took it within the first 90 days, you were more likely to pass. But I'll just say this: take it when you feel the most confident and the most prepared for you, because you only know that for yourself. If you're looking for something cheaper, APHA has a resource as well. They do a really good job over the last several years, at least, of updating this yearly, also similar to RX Prep. It's a little less intense on the pocketbook, and so a little more cost-friendly. And if you're an APHA member, there is a discount that is given and provided to you. Be sure to check too, because sometimes this month they know that many students or graduates are going to want this, and so they will offer even a bigger discount. So that may be something to look at on the website. You can go to pharmacist.com to check that out. I will say this book, I've looked through it. It isn't as overwhelming as the RX Prep, which is really thick. This one is easy to get through, so just keep that in mind. And if this is something that, if you feel like math and calculations is something that you really struggle on and want more in-depth focus on this, they also have, APHA has a complete review for pharmacy math, which is a self-guided practice problem-based questions that you can navigate through. And I think this is very helpful for those that really want some more intense work on math calculations so they can strengthen their knowledge there. I have this listed here because ASHP used to have a book that was out, and you may see it if you do like a quick search via Amazon or eBay. And just be very careful. You can find these very cheap, but this one is pretty dated. It's from 2011. So as you're looking at resources that are out there, this doesn't talk about all of them that exist. There are many others. These are just some of the common ones I've seen. You'll want to be careful of the copyright date and try not to get lured in by such a cheap price, but then you start looking at it and it's really dated and old and out of date. But how many of you like free stuff? I don't know about you, but I really like free resources. And this is something that if you have free access, take advantage of this and use it. Check with your school's library. I know for specifically, I can speak for Butler, we have a resource to access pharmacy, specifically Naplex Central. And there are resources that you can access online to take practice problems through McGraw-Hill's Naplex review, some of the examples I have listed here. There's other places where you can go within that and set up your own custom quiz on a variety of topics based on the chapter and set it up. You can see the example here. You can set up a quiz that has 250 questions, set a timer and go and check yourself. Many of you hopefully have been using this throughout, if your library has resources like this throughout your P4 year and doing little practice quizzes. If you haven't, you can still access these. I believe most schools still provide access to graduates throughout the summer to the library resources. Some may even offer them indefinitely. So check with your local school on how long you will have that availability. And I want to also mention this. This is something that many of you probably remember way back when, especially if you worked in the community setting, the little Mylan book that was brand generic conversions. And so some pharmacies have these, many technicians love to use this. Well, they've started to stop sending the books and you can download the app onto your device. And this is free. Mylan is now merged with the Vitris, so you may want to check to see if it's how it's set up. I looked over the weekend and it was still available and you can still download it for free. And this is a great tool just to kind of test your knowledge on brand generics. And if anything else, it might be good as you're out in practice for the first year, as well as you're still navigating things. Now, how much is this all going to cost? That's one thing that I always hear graduates ask me. Double check the fees on NABP's website. I did look, and I believe the exam fee for both Naplex and NPGAE is the same as listed here, but double check the application fee. Sometimes that's hard to find, and it's one of those hidden things where there's an application fee, but then you also have to take an examination fee. So it ends up being $100 plus more than you thought you were going to be spending for this. So, and it isn't cheap. And so be sure to prepare for that. That's something else if you're looking for a little more expensive graduation gift. Hint, hint, maybe your parents might do, or this may be something where you're having to, one last cost that you're having to fork over before you become licensed as a pharmacist. So check the fees, check the costs as you're navigating and preparing for the exam. This slide is from the NABP's website as well. It's a navigation of the steps to apply. Obviously, all the schools have to submit to the state board, specifically here in Indiana, your intern hours that you, to show that you successfully completed all of the hours required on your externships to sit for the board exam and that you actually have your degree conferred. Also keep in mind that NABP, starting with the last couple of years, have required transcripts be sent directly to NABP. So work with your schools to find out how you have to go about doing that, whether they want to send it snail mail or can upload it through an email address to NABP, whatever works best or is preferred that your school provides. Most have vendors that work with the school that they can help make this happen pretty quickly. And so look at that. Some states, depending on where you go, you may want to check with them as well because they may also require an official transcript from the school sent to them as well. Indiana, to my knowledge, does not. Just your intern hours, and all schools send that, but double check specifically which state, if you're going to somewhere else, what they may require because it could vary and be different, okay? All right, so with that, I believe that concludes my helpful tips on the Naplex. All right, so I'll stop sharing that. Bottom line from that is good luck, and obviously try to do the best you can as you study, prepare, and like I said, only you know how much time is needed for you to study. Okay. Yeah. Bear with me as I take a few moments to pull up my next slide set. Okay. Before I begin, I'm going to do a quick poll. Okay, so we're going to do a poll. And with this, I want to ask each of you this question. Would you prefer that we stop to answer questions at the end of the session or do them as we go? Okay. I do have certain placeholders as we navigate from one topic to the next, and so that might be a good pausing place, but I'm happy to do with whatever works best for each of you. So we'll give you a few minutes to. Okay. Can you all see the poll responses? Oh, I guess I can share the results. I have to hit share results.
I just did. We should be good.
Okay, perfect. So it looks like the majority would like to do them as we go. Okay, so I will do my best to do that. If I see a question or if I miss it, I will do my best to check the chat. If for some reason I miss a question that comes through, I will make sure I preview these as sort of at my stopping placeholders throughout as I navigate from one topic to the next. I try to divide my questions up based on topic of OTC, and so I hope that we can, I will do my best. All right, so hopefully everyone's able to access the slides. Again, you can access them through the link in the agenda. You may have to do Control-click to access those. If you don't have that agenda readily available, you can, if you have a touch screen, you might be able to touch this link. If you don't, you can try to type this in. I did shorten it to a tiny URL, so if you didn't have access to the link here, you could use that quickly to pull up the slides. Because everyone's trying to get into this document at the same time, it may load a little slowly, so just be patient. But hopefully everyone is, if someone could give me a thumbs up if they're able to access these, so I know I'm not halfway through before I realize no one is able to access. Okay, I've got a hand raised. Thank you, Kayla. All right. Okay, it sounds like everyone's good. I'm assuming the hand raise means yes. Okay, how we're going to break up today's session for OTC. Again, I know OTC is something that you got exposure to on your IPPE experiences when you went to community, and that's been a while. You also had your APPE experiences where you worked in the community setting, where you also were exposed to this. And many of you have an over-the-counter course at your schools. I know at Butler we have self-care and health promotion, where we use an OTC approach to therapy. So hopefully for many of you, I hope that these are reviewed. This is not intended to be a comprehensive crash course of that. I mean, I know ours is 2 semesters long, so it would be really difficult to squeeze all of that in this condensed time. And so this is not meant to be learning it for the first time, but will hopefully be review. The way I went about this is I took questions that I have heard from other students, that I've seen out in practice, and also from review guides to help us go through some of these. We're going to start off with GI, gastrointestinal, and so I know that's a lot of questions on this, but there is a lot of products when you start looking at the breakdown of some of these. I'll also interdisperse several other of these topics. Many of these may look familiar. We will be getting you all engaged, so we'll be doing a polling questions, and so appreciating your response as we navigate these questions. And then at the end, we're going to switch it up, and I'm going to do a Kahoot game as well, which is always fun and interactive. And if I put you to sleep, then hopefully that will wake you up toward the end. Okay, but again, hopefully these questions are not deflating to you. I don't want you to feel like, oh my gosh, I need to really study a lot. This is just throughout the day, use this as an opportunity for what you know and what you don't know. And on things that you don't know as well or isn't kind of as natural to you, feel free to make a note of that and make sure that you go back and review that. All right, so let's kick off with gastrointestinal disorders. So we've got a patient case here. This is sort of similar to how you might see a patient profile here. A couple things that I'm just going to point out here. As I move to the next slide, you won't be able to see this slide unless you navigate back to look at it. On the exam, you would still have access to that case. So it's not like you're going to hit this and then have to move forward. But things to look at, check out your patient's age, because remember, certain products may have age restrictions. Check out your allergies. Usually if allergies are listed and there's something there, it's for a reason. That usually means they're going to ask you a question and that allergy is going to come into play. Review the medications. Again, you're not going to memorize all of these because you're going to be able to look back, but sort of look to see if their current diagnoses or past medical history, however it may be listed, if things look consistent, look for drugs that are duplication and maybe or interacting with one another. So those are some highlights and things that you would want to quickly overview. Again, I always personally like to read the question and then go back to the case, because I didn't want to spend too much time on the case and then realize, okay, I didn't even need that case to answer the question. So some will be interdispersed where the case will be there, but you might be able to answer the question without even using the case, such as this first one. So we've got this patient is using Protonix once daily. Which of the following is an appropriate substitution? So I'm going to use this to, I believe, Stacy, can you see the poll? Is it visible?
I can see it. I'm hoping they
Okay.
can as well.
Can I get a hand raised from one of our graduates, soon to be graduates? Can you see the poll? Okay, so it looks like
they can.
Okay. So go ahead and put in which would be an appropriate substitution. This is a simple, easy brand generic substitution. So I'm not seeing any answers yet. So either people don't know or.
Oh, we've got some answers coming in right now. We're at 7. Oh, wait a minute.
Oh, okay.
I can't see the poll. Hold on one second. Let me try it here.
I think okay. It looks like it's.
I think our old poll automatically popped up on us instead of this one.
Oh, got it. Okay. Okay, let's see.
It's only showing the results.
It can't answer. Okay, bear with us. Technology. Gotta love it. Let me stop sharing and maybe we'll do a reset. Let me do a reset on the poll.
How about now?
Oh, now it's working. Okay.
Here we go.
Safety to the rescue. It takes a team effort, everyone. So this is perfect. Okay, I'm seeing responses. Again, this is one of those brand generic questions. To some of you, these may be simple, and that's great. Answer them and move on. These are quick ones. But for some, you're going to second guess. You're like, oh, I should know this. This is a simple brand generic question. And I'm facing what to use or what to say. So Protonix, which is, so we see some, okay, I'm going to end the poll here. And can I see a hand raise if y'all can see the results? Okay. Oh yeah, I'm seeing hands. Oh, thank you. Thank you. Thank you. Okay. So the correct answer here is C, pantoprazole. This one is, if someone is on brand name Protonix, you could use the generic pantoprazole. This is a simple brand generic question, so you'll be asked some of those throughout. Okay. Let's move on to the next question. Okay. All right. Let's see if we can reset. See if I can reset the poll. There we go. Okay. If the patient is still experiencing symptoms despite current therapy, the physician decides to initiate meclopramide to control reflux symptoms, which would be a better option. So here you have to think about which one is going to work quickly. Which one is going to be the next best add-on to quickly relieve symptoms if someone is still having symptoms despite meclopramide. Okay. And in this case, the next best option would be to, we're going to end the poll, share results. Correct answer would be B, to add famotidine. Now, famotidine has recently gone through some OTC reformulation. We're going to talk about, especially with later on when with Zantac being reformulated. Most people think of this as Pepcid, right? But also now Zantac, which is reformulated with ranitidine. So we'll come to that later. Okay. All right. Next question. Let's see here if I can resend. Here we go. Perfect. An elderly female presents to the pharmacy. She does not have health insurance coverage. Which of the following PPIs is available over the counter? Notice this is select all that apply. So you should be able to select multiple responses for this one. These are a little bit tougher, right? So this is going to ask you which ones are available over the counter. Okay, we'll give a few more. Okay, let's check our results here. Okay, so Zegerid, think about the ingredients that are in this one. This one is available over the counter. Yes. So this one is omeprazole and sodium bicarb. So it contains both ingredients in this one. Prevacid, this one is also available. This one is lansoprazole. So you make a note of that. Also, Prilosec. This one is just omeprazole only. Now, earlier I asked a question. The first question we asked was about, which would be a substitution for Protonix, and Prevacid was the correct answer. That could have thrown you off because Prevacid is not, or I'm sorry, Protonix, pantoprazole is not available over the counter, but Nexium is, and so Nexium is as omeprazole. So all of these agents would be available as over-the-counter options. Okay, moving to the next question. Okay, choose the best answer to this question. A patient's entered the pharmacy and it's asked the technician for help locating the store brand version of Pepcid. Which of the following should the technician select? Okay. Wow, many of you are getting these, so this goes to show that your time and community setting is helpful. But these, again, use these opportunities for when you get questions like this to build your confidence. Yeah, I know that. That's an easy question for me. And so the correct answer here is famotidine. Now, this is what I was kind of alluding to earlier. Pepcid, we know of as famotidine. So if you probably heard me earlier, I may have given this answer away by saying that. Now, what else is Pepcid? What is Pepcid? It's not a PPI, right? So it's an H2 receptor antagonist. So that's knowing the classifications of how these are. Also, what other OTC brand name contains famotidine now? Well, if you look, Zantac 360, Zantac no longer contains ranitidine after that was pulled back in 2000 due to potential for cancer, due to one of the elements in the ingredient. But Zantac 360 does have famotidine as well. So that's just something to note. And I'm going to use this moment to check my chat. Yep. Thank you. I see H2 receptor antagonist. Thank you, John. Okay. All right. Nice work, everyone, so far. Hopefully you're feeling comfortable. This one is I like this question too. So let me reset this. Proton pump inhibitors can increase the risk of, and this is a select all that apply as well. This is that type of therapeutic slash OTC, it's a therapeutic question, but it's related to an OTC slash RX type question. But I wanted to throw this one in because it is a select all apply, and it does sort of ask you to tap in your knowledge of what are some long-term effects of using medications. And so let's go ahead and end this poll here and share the results. Okay, so does this one cause bone fractures, long-term use? And it's like the majority said that is true. Can it cause C. difficile diarrhea or infection? Yes, long-term use has been associated for risk of that. What about stroke? Nope. The hypomagnesia, this one is one to also watch out for. Now, this next one's a little bit controversial. And depending on the source, now there has been some data as of 2022, which is very recent, that they have found that chronic proton pump inhibitor use had a 44% increased risk of dementia compared to those that didn't use a PPI. So there is some thought that long-term use could be associated with dementia as well. So all four of these. What are some other things to think about that PPIs could cause that I don't have listed on there? One would be pneumonia. There has been some data to support that. Vitamin B12 deficiency. So if you want to write these down in your notes too. And also chronic kidney disease. So those are just a few others that I don't have listed on here that have also been associated with long-term use of PPIs. Okay. Let's go to the next question. Which of the following statement is true regarding over-the-counter H2 receptor antagonists? Now, as faculty, we usually don't like these types of questions because you're using A and B as an option instead of a select all that apply, but there could be some that are like this on the exam. So I wanted to throw a few of these in just so you would get familiar with a different variety and style of question. So true about H2 receptor antagonists. Okay. More answers coming in. All right, let's go ahead and show our results. So the majority went with D, A and B, and you would be correct if you went with that. So let's kind of break these down a little bit and talk about them before we just breeze through this one. H2 receptor antagonist, it says, do not exceed 2 doses in 24 hours. That is true. Usually these are dosed twice a day, especially if they're taken scheduled. Are approved for children 12 years and of age and older. That is also true as well. Back on question A, PPIs, those are typically dosed how often, if you think about that? Those are usually every day, right? So these are long acting, but not as long acting as our PPIs. So that's something to keep in mind. Why is C? Think about why C is incorrect. First, sometimes you'll read it and you'll be like, well, that sounds like it could be right. But this one says they are approved for the treatment, but not prevention. And that's where this question C is, our answer option C is wrong, because they are used for preventative as well. You can take them prior to. So They relieve and they treat. So that's one thing to keep in mind. So write this down. This is something to note. Your H2 receptor antagonists, they are approved in 12 and older. Your proton pump inhibitors, how do they differ? They are approved, and this is OTC dosing. Obviously, RX could be different, but if it's OTC dosing, usually it will tell you that 18 and older. Okay. Now, what about antacids like calcium carbonate? We sometimes don't think of them, especially in our adult population, but they can be used in patients that are 2 years of age and older. So those would be, looking at your age of your patient would also maybe dictate which one you select and go with, okay? Okay. All right, let's relaunch this one. Which the following statements is true about antacids? Okay. This type of question is one that I think you'll likely see, and I'll explain some fundamental approaches with this one as to how you can go about answering this one. The main thing to walk away when you're approaching this question is anytime that you see aluminum in the question or in the answer responses, I want you to come up with some way to remember this, and this may just be remembering it, is that aluminum is associated with not diarrhea, but constipation. So aluminum is associated with constipation. Magnesium, on the other hand, is associated with diarrhea. So even if you didn't know the other options and wasn't sure, which of the following is true, and obviously with antacids, usually those are more shorter acting; they're not longer acting in duration. Keep in mind that your PPIs and your H2 receptor antagonists; those are every 12 hours, or daily for PPIs. But where this is, they'll try to trip you up. They don't mean to. They just want to make sure is making you second guess yourself. Does aluminum cause constipation or does it cause diarrhea? So just knowing that aluminum causes constipation, magnesium equals diarrhea for the most part. Okay. And I think that if you use that approach, you'll be able to navigate these just fine. So the answer there is C. Okay. All right, you're all doing good. Okay, which of the following medications is not recommended in patients that are breastfeeding? Obviously, we want to make sure that we aren't recommending a product that could harm the infant, and breastfeeding is a potential for that. So we want to be very cautious. Something that might have been safe for the mother to take, then when breastfeeding, then it suddenly becomes not safe. Okay. All right, in the poll, and the majority got this one as well. Bismuth subsalicylate. So what is bismuth subsalicylate? It is, anyone know? Anyone want to take a stab in the see some chat? Pepto, yes, Pepto-Bismol. So this one's Pepto. Now, with this one, OTC label states that it can be used in children 12 and older. So that's a note to keep in mind with this. It can pass through the breast milk. And what is the concern with salicylate agents in infants or children? Yep. Ray's syndrome or Reye's syndrome. Yes. Good job. Excellent. Yes. So that's the key reason for that. That could be another question that you see as well. Okay. So here we've got a patient that reports frequent belching, sour taste, the back of the throat, trouble swallowing, abdominal bloating, and nausea. Which of the following is an alarm symptom that excludes this patient for self-care? So looking at the options that we have listed, which one is the alarm alarm symptom, which would mean exclude from self-care treatment? We would need to refer. I like this question because it not only wants you to find a treatment, but it's digging into some of the exclusion criteria for treatment. A big topic like this would be a perfect example of where you might have to know that. And so there we go. Good job. What is dysphagia? Anybody want to? Yep, trouble swallowing. Thank you. Wow, inability to swallow. Good job. Okay. Okay, this is a simple, it seems simple on the surface until you start thinking about it and you're like, oh, I know what XLAX is, but now I can't remember. Like if you hadn't asked me, I would have told you. And now that you've asked me, my mind went blank. I can't figure it out. So regular XLAX. A little diverse options on this one. Now you all have got me second guessing myself on this one. So this one is the primary regular XLAX is dun, dun, dun. It's Cinesides. So this one is Cinesides. Also could be Cinesides is also what other brand name is Cinesides associated with? Senecot. Excellent, Senecot. Bisacodyl would be Ducalax. And docusate colase and methylcellulose. What is methylcellulose? I'll give you the answer on that one. It's usually like citracil, so in the fiber. Citracil is methylcellulose. Cinesides is a stimulant laxative. So keep that in mind. Okay. Okay. Move on to. Oh, I think I just gave you the answer to this one. See who was paying attention. Active ingredient of citracil. I should read my ahead questions before I get the cat out of the bag. Huh? Yes. So this one is, hopefully everyone gets this one right. Methylcellulose is a bulk forming laxative. And so a good example of this one is methylcellulose. Now, let me look at my next question, make sure I'm not going to be giving away any answers here. Okay. Calcium polycarbonyl. This one is an example of what brand name would this one be? For the sake of time, I'll just tell you this one is, yeah, Fibercon. Very good, Fibercon. So this one is Fibercon. Psyllium. This one is also a fiber agent as well. Metamucil. Thank you. Yep, Metamucil. So Metamucil is the psyllium. So knowing some of these so you don't get confused on an exam, like methylcellulose, okay, this one's citracil, psyllium, that is Metamucil. Similar type product, they both contain fiber, bulk forming laxatives. Remember these bulk forming laxatives, if you're asked about mechanism, these help absorb water and increase bulk and moisture into the stool. Okay, all right. So methylcellulose is our correct answer there. All right, number 12. All right. Which of the following has the fastest onset of action for the treatment of constipation? Okay. Correct answer on this one is, in fact, A. So this one is magnesium citrate. So this one is, most of these have ranges, nothing's exact when it comes to like, everyone's a little bit different. So many of these have ranges. And so you have to kind of think about which one, this would be a good rank question, would it like rank from fastest onset to slowest or quickest. And so usually on average, magnesium citrate is anywhere between 30 minutes and 6 hours. So it is definitely the fastest. Say maybe a little bit longer, usually 12 hours to 72 hours. That's a long range. But think about, which ones are stimulants versus acts as a stimulant versus which ones act as like a softener. Psyllium is usually anywhere between 12 and 24 hours. And synicides is anywhere between 6 hours and 10. So if I were going to rank these, I would think mag citrate would definitely be first. Synicides would be second, fastest, and then hopefully they wouldn't try to trick you up with docusate and psyllium. That would be kind of tricky when it comes to ranking because they both could be within that 12-hour window, but with docusate being probably a little bit longer though. And then what if Miralax was listed on here? What if our PEG agents? That one is usually within 12 to 72 hours as well. So I think if you know that mag citrate works quicker, that'll be good. Synicides would work quicker than docusate and so forth. All right, this is a different type of question that format. This is what we call K-type questions. And so many schools and the Naplex sort of went away from using these because one, students didn't like them. Personally, between you and me, I liked it better than select all that apply questions because I could usually figure it out by ruling out something of the three options. And then, okay, I know that one's not right. So let me find out which, narrow it down. So I threw these in. I don't know that there'll be a lot on the Naplex, but law exam, I've been told, still will contain some K-type questions. And so hopefully, just in case you didn't have any experience with navigating these types of questions, I wanted to throw a few in for that reason. So that that would be the first time that you saw these. Many schools phased using these out as well. I know at Butler, we used to use these all the time. And then we're like, nope, if Naplex is phasing them out, we're not going to do them either. And then we're told by some students that, oh, but they still have a few on there, or MPJE does. And I'm like, well, we need to prepare our students for these. So this is what I'm doing now. Okay, so in the poll, share results. Correct answer on this one is C. So let's kind of walk through this one a little bit. So which is true of bulk forming? So can they cause bloating and flatulence? Absolutely, it's fiber. So yeah. Should be taken with 8 ounces of fluid. Yes, you'll want to mix. Usually these you have to mix with water as well. Otherwise it's going to taste really bad. And should be used for the treatment of acute constipation. Now, while they can work fast, usually these are not first line when it comes to acute constipation. If someone is really constipated, these could actually bulk up in the GI and worsen some of that acute constipation. So you usually want to use one of your stimulants first for quick or mag citrate, but usually your bulk forming fiber agents aren't going to be your immediate relief. So the correct answer here, if you know 1 and 2, If you were on the fence and not sure about number 3, then yeah, you would go 1, 2, 1, 2, and 3, which would be E, but the correct answer in this case would be C. All right. Let's take a quick little just refresher and regroup, and now change our focus on OTC, cough, cold, and flu, and allergic rhinitis type questions, okay? You're all doing great so far. Okay. Okay, we have a patient that presents to the pharmacy that wants something that is what they think is for a cold. Notice their symptoms that they have here. So these may be things you want to take note of. They're shaking, so that tells us they've got chills. Started feeling terrible yesterday. Have myalgias, arthralgias, so that's basically the muscle aches, fatigue. They've got a productive cough. For those of you that know that I teach this topic in self-care, know that you need to know not only that they have a cough, but you have to ask what type of cough. Since the patient's not there for you to ask, the question should tell you. They also have a runny nose. That tells me they've got some cough going on. They have a stuffy nose too, so that tells me they've got some congestion going on in their head, some sinus congestion, and also alternating with runny nose as well, which sometimes happens when that starts to drain. So they've been sneezing as well. So we've got some maybe allergic rhinitis and cold going on too, or flu. But the myalgias, arthralgias is going to tell you that's probably flu. And we've got no allergies, which is good. All right, let's get to the question. Which symptoms indicate that this patient is suffering from influenza virus rather than rhinovirus? Now, rhinovirus is a fancy word for the common cold. Most common colds are associated with the rhinovirus. Influenza is obviously going to be the one that's associated with the flu. Now, let's assume it's not COVID in this situation, which is another reality that we have to factor in there, right? This question I like, not only because I asked it, but any review book that I see that covers OTC has a question somehow related to these types of questions where you have to figure out symptoms of cold, flu, allergic rhinitis, and so forth. And so I always like to include these in my reviews. So in this case, you'd be right if you said B. Ooh, now we had, let's see, influenza. Now let me think here. Oh, it's like all applied. Maybe. Oh wait. I think you are. Yeah, you're right. I just had to click it again. It's like, wait a second. So yes, the fever and the chills. Those are your two indicators that this patient. Could you have a fever with a cold? Maybe, but typically that's more cough, nasal. The myalgias is the one thing, and the chills. Abrupt onset could happen with either one, and sinus congestion could be either one. That's not going to, I mean, it could be flu, it could be cough, or cough cold. It's not going to be the differentiating factor either way. So the ones that are really differentiating is this fever and the chills in this patient. Okay. All right. Next question. Which one indicates they're suffering from the flu rather than seasonal allergic rhinitis? This is a select all that apply as well. Okay. All right, let's end this poll and share our results. So the fever again, allergic rhinitis, we rarely see fever, right? And the myalgias in this case as well. Now, rhinorrhea, that's essentially patient has a runny nose. That's very common. Could it be in the flu? Absolutely, but it could also, that alone wouldn't tell you if it's allergic rhinitis or the flu. Same thing with cough. Postnasal drip might actually create a cough as well. Okay. This is another select all that apply. Wants to choose a product that will cover all of their symptoms. Which active ingredient should the product contain? So this is where you'd probably have to go back and look at all those symptoms the patient had. And remember selecting the ingredients that are going to actively treat the product or the complaints that the patient has. In this case, you'd be able to go back to the case to see. Here, for the sake of this, we're not going to do. So hopefully you can remember all those symptoms that the patient had. I think we knew they had a fever. We knew they had some sinus congestion, but they also had a runny nose. So you might want both of those. They did have a cough. So this is going to be where it's key on what type of cough and which ingredient do we want to treat that cough. So one of the, so you could probably say, okay, I know it's A, B, C, but is it D or is it E? I'm going to pin the poll here, share the results. So with this patient, what type of cough did they have? They had a productive cough. So the difference there is that the patient is coughing up junk when they're coughing, right? So we need an expectorant to help expel that. An antitussive would suppress it. So if they had a dry cough, an antitussive would make sense. But generally, you never want to suppress a productive cough. So if someone has a productive cough, you wouldn't want to use an antihistamine to suppress that, because that's your body's way of facilitating that you need to get that out, and you want to expel it and get rid of it. So keeping that in the body only increases the risk of potentially an infection or some other type of maybe pneumonia if it's deep down in the chest. All right. So the correct answer there was A, B, C, D, and E. All right. Next question. Another case. We've got a patient shows up to your clinic. They've got a dry cough for 3 days. Denies any fever or chest congestion, no nausea, vomiting, diarrhea. So that's kind of ruling out any exclusion stuff. They do have hypertension and a rash with codeine. There's the medication they're on. We can argue whether or not that's appropriate for their hypertension or not at another session. So you have something in the chat. I'll take a look at it in just a second here. Here we go. The dry cough is hyperactive and interfering with the patient's normal activities. Which of the following is indicated? A dry hyperactive cough. So the dry cough, 100%. Good job. You're all paying attention. And we'll share results. Yeah. All right. A is the answer, a cough suppressant. An expectorant is if it's a productive cough. Okay. Next question. I want to check out the chat up there after we do this next one. Let's okay. Diphenhydramine is an active ingredient in OTC products used as a cough suppressant. Its antitussive effect is due to, and this may be something new for some of you, diphenhydramine, we usually think of antihistamine, right? That's usually what it's classified as. But if you'll recall, diphenhydramine also has some antitussive properties. That's why we commonly see it in a lot of the OTC products. One, because of its sedative effect, which will help patients sleep, but also because of its antitussive effect. Now, I know this is one of those, it seems tricky on the surface because I can tell by how some of you are saying C, and that would probably what I would say if I didn't know the answer as well. I'm like, oh, anticholinergic, it's going to dry up the cough. It's actually A, so it works centrally, involving the medullary cough center to help suppress the cough threshold. So it basically increases the cough threshold so that you don't, so it suppresses the cough. All right, let me check out my chat real quick. Okay, looks like it was for question for number 3. Let me go back. Yeah, so to clarify on number 3, the answer was A, B, C, and D. Yes. Okay, sure. I'll go right back. It says go back. Why 3 needs an antihistamine again. Okay, so let's go back. I'm gonna see if I can go back here. Okay, so here was the question. Which one of them would which one do they need? And so why do they need the antihistamine? If you go back to the case in this one, the patient also had a runny nose. So the antihistamine would be good in that case for the runny nose. Now that one contradicts what I just said about antihistamines being antitussive as well, right? In that case, so hopefully they won't get that tricky with you. But in this case, we were mainly using the antihistamine to help treat the patient's runny nose. They also had a stuffy nose, so we were using a decongestant for that as well. So that's why we went with all 3. I recognize that question probably had like the kitchen sink type answers, which is normally not the case. In that sense, someone has the flu, they're probably gonna need more of those. Okay, makes sense. Okay. Let me see where I left off. Yeah, okay, I think we're on this one now. Relaunch. Okay. We got a patient that has sinus congestion, productive cough. Notice we've got some descriptors here. Patient denies any fever, nausea, vomiting, or diarrhea. They ask the pharmacist for assistance. What are we going to do? Okay, in this case, if you said, so on a quick glance, you're thinking productive cough, we want to facilitate that. Many of you were going with the guaifenesin approach, right, to help facilitate that productive cough. This is where the details come in on this one. You have to look at the descriptors and remember your exclusion criteria. Where a purulent cough, what does that mean? And so here we've got a descriptor, it's a dark green and purulent. So usually this is thick in nature if it's purulent, could be pus-like. Typically, purulent means that it's some type of color. So it's either off-white, yellow, green, or opaque, or like a dark yellow. Now, I'm not talking about postnasal drip, light yellow. We're talking like a dark green, like gray, thick. In this case, this would be purulent, and that is an exclusion criteria. So in this case, this patient would need referral because they could have something else that's actually going on. Now, you may be asking yourself, well, would guaifenesin hurt them? Probably not. I mean, it's a productive cough. You'd still be able to use guaifenesin to help facilitate that up. I mean, even if it's purulent, we want to try to get that out. But at the end of the day, there is something underlying going on. It could be a sinus infection as well. They don't have a fever, but I've also had sinus infections where I've not had a fever either. So one of the exclusion is if it's dark in nature, the color of the sputum. Obviously, if it's red or bloody, that's also an exclusion as well. So just sort of pay attention to not only what it's asking, but then look at the details as well to see if it's leaning. If it's got a referral as an option, look at the details carefully to see if do those sound like exclusion. Even if you're not for sure and don't remember all of them, think about those. If exclusion or referral is an option, that doesn't mean it's the answer always, certainly, but look at the question stem again to see if there's some information in there that's leading you to that answer. Okay. Okay, here we've got a patient prevents complaining of a clear productive cough for 2 days. Sinus congestion, does not have a fever, which is the most acceptable option in this patient. So this one's a little more, oh, I'm sorry, would not be. So this is where you have, I think I've read through this really quickly. I don't know if I caught that not, and I even have it capitalized. So I have it in there to ask a question for this reason. Usually we don't like these types of questions as faculty because we feel like they're tricky and they are set up to trick a student, because if you read it fast, you're like, which would be acceptable? But it's asking you which would not be acceptable. So I need to find something that I wouldn't want to use. So that may rethink how you look at your answer options. I didn't put this in here to purposely be tricky. I put this in here to remind me to use that as a teaching point, to read the question. And if there's something in capital letters, or if there's a not all of the following except, read that, because otherwise you could answer this wrong. I know these are tricky inadvertently. So let's end this poll. Share results. So which one would we, so they have a productive cough. And we just said earlier, we don't want to suppress a productive cough. And so right away, I'm going to look at what I can do to rule out. So I wouldn't want to use I think there should be two answers here, and I think I've got this one keyed wrong. So double check. There should be one other option on this one. I don't know that it's going to come up. This should be a select all that apply. So make a note of this. This one should be dextromethorphan and phenylephrine, because you don't want to suppress the productive cough. So if you said A, you are correct. And it should also be E, which we go back. E as well, because that is dextromethorphan and guaifenesin. While that ingredient is common in several of the different OTC options, that negates the effects of one another, right? So you're suppressing the cough, but yet you're also trying to expel the cough. So rationale behind that one doesn't make sense. So anything with dextromethorphan in this case would not be accurate. So if you said A and E, you have it correct, and I missed it because I did not have E set up to default. So I'm going to make a note of that so I don't miss that for the future. That's what happens when you get in a hurry. Good catch for those that, as I read it, I was like, there's two answers here. This isn't right. Okay, next question. Oh, before we move on, I see there's a chat. Let's see. What other situations for referral that we would see on an exam? That's a great question. I would say probably with GI. I would say GI would be a good one. Constipation, cough, cold, and flu. Those are some of the big ones that I would see, knowing like your referral. Like, what is the alarm situation for GI? When would a patient, what are your exclusion? Those are some big ones. I'm going to think about that one too, and I'll come back to think if I can think of any others. But I think any of the two topics that we just covered would be specific ones where you might see referral. Okay. All right, let's do. Can't tell if I launched that one or not, so sorry if I did. Let's go to the next one. So, all right, here we go. Nasal delivery systems. This is something that I think is important. I have seen many review books contain these types of questions. I've also talked to graduates and they say, yep, I had one on there, or two. And this is about proper use of the nasal devices for cough, cold, and flu. Some of them you have to tilt the head back. Some of them you're upright with your just straight ahead. Some you have to tilt your head back. And then the difference. And so which of these is important to tilt the head back when administering? And this one is think about this one for a minute. Go ahead and share the results. This one's going to be C, nasal drops. So these are the ones that you usually have to lay your head back over the edge of a bed or over an armchair or have someone do them for you because you want to keep the head back so the drops don't run down. Now your atomizer one, that's the one that you squeeze and it kind of shoots up into the air, the mist. That one you want the patient upright, just looking straight ahead. The metered dose pump spray is the one that you usually put your thumb on the bottom and your fingers on the top. And with that one, it's sort of actuated to give a set amount. And you want to make sure the head is tilted lean forward when doing that one. And that's mainly to help with the direction of the nozzle of the device. Can we get an example of each of these? Okay, yeah, actually, yeah, hang on one second. Let me, I think I have some in the drawer right behind me. So let me pause my video and I will be right back. Okay. Okay, I should be back on now. All right, I will do the best of my ability to sort of show you what these look like. An atomizer nasal spray, this one's gonna look like, just to refresh, what these look like. It's sort of your tube like this, so that when you take it off, it's tipped like that. And then when you squirt it, the mist kind of goes up in the air. My laptop's now a little soaked. And you may not have seen it there, but it's sort of where you would put this into the, with the atomizer one is one where you want to be upright. And then you insert it into the nostril and squeeze. Some of your books online or your textbooks may have pictures of these and how to use them as well. That's the atomizer. So it's based on how forceful you squeeze it, really how far up the mist goes. Meter dose pump inhaler. This one is probably the more common one now. It looks very similar. The tip's a little bit larger and it's got a place where you put your fingers here on the top and your thumb at the bottom compared to the one I just showed you where you just sort of squeeze it. This one, you can't squeeze this bottle. This is the metered dose pump spray. And with this one, you sort of similar thing. I'm not actually inserting this in my nose, by the way. So you would do it this way and you would lean forward. Okay, and that's the metered dose pump spray. Usually with these, you also have to prime it for the first time because, especially if it's not been used for a while, you might not get the full amount up. This one also does it in a stream, whereas the other one does a mist that goes out. The atomizer does more of a mist, whereas this one does a stream straight up, which helps to lean forward. The nasal drops, a lot of these are, I don't have one of those, but it's usually a dropper bottle with a little syringe that you pull out. And so with that, you have to lean your head backwards over the arm of a chair or a bed. I'm not going to lay back here in front of you all today, but I will also show you, here's a nasal saline. This one isn't atomizer, but any atomizer when turned upside down will function as a drop. If you slowly turn it upside down, you'll watch the drop sort of drip down. So atomizers could be a drop depending on if you squeeze it. It's an atomizer. Turn it upside down, it becomes like a drop because it drips it one at a time. And then the nasal inhaler, this one is an example. These are usually heated, mentholated. These are like sort of like the Hall's decongestant menthol, and you just insert this in the nose and sniff. This one, it doesn't matter how you tilt the head. So hopefully that helps to kind of get an idea of what some of those look like. Those are the common nasal decongestants that you'll see. Okay. Great question, and luckily I had those right behind me. So, and those were not ones I used for personal use. Those are ones that I use for demonstration. All right. Next question. Due to the potential for rhinitis medicamentosa, product labeling recommends using oxymetazoline no longer than okay. So first you have to ask yourself, what does rhinitis medicamentosa even mean? And if you've forgotten, this will be a great opportunity to refresh. They could use words like this that you're like, wait, I think I know what that means, but I'm not really sure. And then you have to remind yourself what's oxymetazoline. So those are the two things in this. Quickly, you want to be able to identify what the drug name is and identify what is any medical jargon that is not for the lay person. That's medical terminology that you may have slept on and forgotten. Yes, and so it is rebound congestion from overuse of the decongestants that are nasal, the nasal decongestants. We don't see these with systemic. And no more than 3 days. Labeling states no more than 3 days. Oxymetazoline happens to be an OTC nasal decongestant. And so that's exactly what it's asking in that case. In this case, oxymetazoline is Afrin is an example of oxymetazoline on the box. Okay. Okay. Patient has hypertension and is needing a product to assist in relieving sinus congestion. Now, these products, which is the best for this patient? Oh, and there's a reason I put this one on there too. Things that we know. We know this patient has hypertension. We know that any of these products listed has the potential to increase blood pressure, right? Decongestants, that's something by nature that they can do. So when I first look at this, I'm like, okay, let's, your first thought should be, okay, what is some non-pharm or some nasal saline that would work that I can use? But these options aren't on here. So I'm like, okay, I got to start again. Which ones, what do I not know? I don't know if this patient's blood pressure is controlled. And controlled blood pressure might be a difference. I mean, used to the school of thought was, okay, if they have hypertension, avoid decongestants. Now the school of thought is, yes, it will raise it, but is the patient controlled enough that they're only using this for a short period of time that maybe they could use it and then be done with it? It's not like they're chronically going to be on this, but we know it's going to raise it. Just monitor until it's worked. So what I'm thinking is, couple things, and I'm gonna wait till we answer, and then I'll share kind of where my thoughts going. I don't want to lead anyone to the right or wrong answer. Okay, let's go ahead and end our poll. So the thing I'm thinking of is I want to use something that is not as systemically absorbed. Yes, all of these carry in the labeling that it could increase cardiovascular disease, could increase blood pressure. And we know that something that's taken orally is going to have more systemic absorption. So right away, I'm thinking, okay, while they may relieve his congestion, I don't know if this patient is controlled or not, and I want to use the one that's going to be the least harmful. So I'm going to rule out C, D, and E because all of those are oral and are going to potentially elevate blood pressure the most. So that leads me to A and B. And my next thing is which one between the two. The rule of thumb is typically if something is shorter acting, it's going to be in the system, not as long, and potentially less likely to interfere with their blood pressure throughout the day. If something is only lasting 4 hours, that means it's going to wear off and not interfere with their blood pressure, especially if you don't use it every 4 hours, you know, if you're only using it less than that. So in this case, the majority of you said A. Oxymetazoline, would that be the next option? Probably after B. I know a lot of times we like the every 12 hours because it means patients having to use it less. There is less, I will say the or the rhinitis medicamentosa is more likely to occur with the shorter acting and repeated use. So that would be a concern to steer away from that. But in this case, we want to use the shorter acting one. So it's in and out, it's in the body and then it's sort of out, even though you could argue that either one of these are less systemically absorbed than the oral. Now, the reason I put this in there is because there may be questions that you get where you're like, I don't like any of these options, and they're so close and so similar. They're both, A and B are both nasal decongestants. If you look at the percentages, you could look at that too. That may have been what threw you off. But in this case, it is the hours. And so you'd want to go with the shorter acting. Okay. So that I threw this in there because I know that there may be times when you get questions where you're like, I don't like any of these, or I'm really stumped, and just sort of look at what's different between the two and then go with what your gut's telling you or what you can remember. So the shorter acting is preferred. Now, if the patient had, if nasal saline was an option, that might have been a better choice. If they said it was controlled hypertension, that might have even been different as well. But I don't think they're going to put you in a position where you have to interpret too much, since you're not there to ask the patient specific questions. They'll have to tell you things. Okay. So next, we're going to turn our focus to OTC and pregnancy. So we're going to have a few questions there. All right. So we've got a patient with constipation, 6 months pregnant, lower bowel frequency is decreased. So the following are we recommending? Okay. Looking at my time, I want to be aware of that. So we keep moving right along. So I may end this poll a little bit early. In this case, this is a situation where, if you can, recommend non-farm. That would be ideal. That's going to be least likely to cause any disruption. Now, some said refer. You can treat constipation in pregnancy. Non-farm is probably going to be the best. And if that's not working, then refer. All right, let's do this one. I'll give you a few minutes to answer that one. I'll read this one to you. Okay, I'm seeing close to 100% on this one. So you'd be right if you said nasal saline in that one. So nasal saline is the correct option in this. With this one, you want to, any of these could impact pregnancy in some way, depending on the trimester. There's a lot of data on guaifenesin, and guaifenesin, if the patient, water would be a great way to facilitate that cough, which is safer. Dextromethorphan, this data on that one too could interfere with pregnancy. And so anytime that you have a pregnancy question, if there's something nasal saline or non-farm, that's probably the way to go with these. Okay. Here we got a patient in second trimester, needs a product for sneezing and runny nose. This one always gets mixed options on this one. This one's one of those questions where I get the outrage on this one, because many of you are going to be upset to hear on this one. With this one, many of you are going with cetirizine because it is a second generation antihistamine, less sedating. Obviously, D and E we could rule out because those aren't going to help with the sneezing and runny nose, right? Those are going to help with congestion. But we've already talked about pregnancy and how we want to use that. But that's not going to treat this patient's symptoms right here, right now. These others are all antihistamine. So we've got it narrowed down to A, B, and C. We know A and B are old school first generation. We know that B is a second generation, usually less sedating. People usually really tolerate this one very well. Pregnancy category shows that it's pretty good. However, the one that gets endorsed from the American College of Gynecology and Obstetricians as the one that's safest, and partly because this has been studied and been around for so long, is chlorpheniramine. And so this one actually is the one that has the most data. As we know, we don't do a lot of randomized trials in pregnancy. So all we know is anecdotal, and the ones that have been around for the longest, we know that. And so I could see the argument on this one because chlorpheniramine is very sedating. Anyone that's taking it knows that. And but because we know that its safety profile is good, we go with the one that's supported by the Gynecologic Society. So we go with A. Okay, I know that one doesn't make people happy to see. All right, let's move on to some over-the-counter pediatrics and children. I'm hearing the rain here in Indianapolis hit against my window in my office. I'm sure nothing like doing a review on a rainy day, so that doesn't make you feel guilty for being out in the nice weather and having to stay in and study. Okay, so let's check this one. Should not be recommended. Antitussives, expectorants, and decongestants should not be recommended. What is the OTC labeling cutoff? So this is going to be a key question. This was huge several years ago when all the more than several, but when reformulation of all these products became about, with products unsure if they were safe or effective in children because they had all been studied in adults. And with this one, the labeling changed specifically for antitussives, expectorants, and decongestants. Notice I've left off cough, cold, and flu antihistamines. We'll get to that in just a moment. But with this one, the correct answer is, I'm kind of seeing a mix between C, D, and E here. So let's see where it is. It is children less than 4. So labeling for OTC cough, cold, and flu, if it has antitussive, expectorant, or a decongestant in it, it is going to say do not use in children less than 4 years of age. Okay, and that is the OTC labeling. Now, what if the product has a first generation antihistamine in it? What would that change to? If that happens, it's going to say, the labeling will say, if it's got that in it, do not use in children less than 6 years of age. So the antihistamine in the cough, cold, and flu products is what guides the labeling for cough, cold, and flu. If it says, if it has a first generation antihistamine in it, the cutoff is going to be do not use in children less than 6 years of age. If it doesn't have that first generation antihistamine and it only has antitussive, expectorant, or a decongestant, or a combination of that, the labeling will change to say less than 4. But if I added an antihistamine on there, first generation, it will be less than 6. So that's the two differences. Okay. All right, next question. Which following products could a pharmacist recommend to treat a patient that is 4 years old with symptoms including sneezing and runny nose? Okay. I see I got a couple of questions in the chat. I'll take in the Q&A as well. I'll look at after this question. All right, let's end this one and share our results. So another K-type question here. With this one, it would be D, which the majority got this one right. So let's kind of talk this one through, and then I want to address some of the questions in the chat. With diphenhydramine, first generation antihistamine for general, we talked about earlier, if this is in a combo product or by itself, this one typically is not used. The children, you have to be not to be used in children less than 6 years of age. Okay. Now loratadine and cetirizine are maybe slightly different. So what is the cutoff on the second generation antihistamines? These can be used in a little bit younger population than the 6 that we see with first generation. These have labeling where they can be used in, they have to be 2 or older. So 2 years or older for loratadine or cetirizine on the labeling. So the correct answer on this one, this patient is 4. So they are over 6 years of age. So that would rule out diphenhydramine. And but we could use the loratadine and cetirizine. Now I want to take a look at the chat for a second. So would they clarify on the exam if the FDA 2-year-old recommendation versus the package recommendation of 4-year-old? And yeah, they would have to clarify on that. I don't think they'll get into that in the weeds on it, but they would have to clarify if they want OTC labeling or FDA recommendation. Typically, if it's an OTC question, it will ask you that. So that way you know what's OTC labeling say versus what something could be used if it was prescribed as a prescription. So that's good. And so forth. Let's see if I have another question here. For the pregnancy 3 question, was B and C not good because it wasn't approved? Let me go back to that one real quick. And that is, yes, that is true. With that one, chlorpheniramine is the one that has the endorsement from the American College of Obstetricians and Gynecologists. And so with that one, that's the one that we recommend, and because it doesn't have that approval. All right. Some general rule of thumb to think about before we segue into our next topic is, things to think about non-farm with our children is drink plenty of fluids, use nasal saline, cool mist humidifiers or waterless vaporizers so it decreases accidental burns or scalds of children, tipping it over and so forth are preferred. Remember, with antitussives, topically used camphor, usually these have menthol and camphor in them, which can burn or irritate the skin. Camphor containing products should not be used in children less than 2 years of age on those because of accidental ingestion and unfortunate seizures and death if children get it on their hands and put it in their mouth. So we want to make sure we avoid that. Other strategies are also endorsed, such as frequent hand washing. This is even in the COVID era. I think these are very critical as well. So keep these in mind. Okay. And our couple more topics before we do our Kahoot. So let's move through these polls really quickly here, but I want to make sure we cover some important stuff on them. We've got a patient here. Which of the following would be the best? This one ends up being trickier than I mean it to be, but pay attention to the details of the question. Remember that. All right, let's end this poll so we can, the majority are going with give another second or two here. Okay, the majority got it right. This one is B, 3 only. So acetaminophen, why did we rule out the other 2? And if you look, there is an aspirin allergy, and there is some potential for cross-reactivity with aspirin allergy and NSAIDs. Now, does this mean always? No. We're not there to ask the question if they've used an NSAID in the past and how they tolerated it and it didn't work. If that were there, I would be doing that. But if I don't know the patient and they have an aspirin allergy, yeah, there is a potential for cross-reactivity. And I would want to dig more into what was the allergic reaction the patient had. What did they experience with it? Have they tried it NSAID? And all of the questions that you would normally ask. But in this case, we can't. And we know that there is some cross-reactivity. So this is a good example of just read the details of the case. If the allergies are there, it's usually for a reason. Otherwise, if that weren't there, the other two options would be equally as good, maybe even better. Okay. Okay, this next question. Okay, so we've got a patient that is presents to your pharmacy for naproxen. What's the max number of days she can take this per day? Okay. This is something that you'll want to know is your max per day of naproxen, and I would even go so far as to say Tylenol as well, which we'll talk about that in just a minute. So with this one, our max per day is 660 milligrams, which would put us at 3 tablets per day. So if you said B, you got this one right. The majority said C on this one, slightly. This one's a tough one. So knowing your max over-the-counter dose limits, and again, they would tell you if it's over-the-counter dosing labeling limits versus what might be prescription, which brings me to the question of Tylenol. FDA still allows a limit of, for FDA-approved acetaminophen of 4,000, right, milligrams per day. But OTC labeling is leaning more toward a lower limit of how much? Anybody know? Anybody with in the chat? Yes, 3 grams or 3,000 milligrams. Absolutely. Thank you. Yep. Good job. So they would have to explicitly say that to not trick you up. But if it's, just actually what's the FDA recommended for would still be correct. If it's OTC labeling, you would go with the 3 for acetaminophen. Okay, let's do another one here. We got a 10-year-old child requesting assistance. Okay. Another K-type question here. For the sake of time, I'm going to go ahead and end the poll and go over this one. Correct answer here is D, which the majority got this one right. So naproxen, remember, 12 years of age or older for OTC, 12 years or older. Ibuprofen, on the other hand, you can use, depending on the strength that you get, there are some that's available for 6 to 11 months, years of age. And for Tylenol, acetaminophen, there's some for pediatrics from 0 to 3 months. So 6 to 11 months for ibuprofen, 0 to 3. Will they get into those details? Likely not, but I would know that naproxen shouldn't be used. And that's the subtle difference between these, is that naproxen's 12 and older, whereas the others can be used even in younger, with the appropriate dose, of course. All right, I want to segue over to a few tobacco cessation questions, since this could be something that you see as OTC. And then we'll wrap it up in the last 15 minutes of my session for a quick Kahoot game, where it'll be a little more faster paced, rapid fire questioning, just recognition. We won't have to spend as much time discussing, but we will obviously where we need to. All right, let's go with this one. Tobacco 1. Okay, so with this one, you're gonna have to draw up on which one is based on cigarettes smoked per day. If you keep in mind, some are based on time to first cigarette, and some are based upon based on the number of cigarettes smoked per day. Knowing that within a package of cigarettes, 20 are in a package. So let's end this poll and share the results. So this would be your A, your patch. So patch is based on the number of cigarettes per day. Remember, to start with a 21 milligram patch, it is greater than 10 cigarettes per day. So greater than 10 cigarettes per day, you would use the 21. If it is less than or equal to 10, you would start with the 14 milligram and then progress down to the 7. So that's just something to know. Okay. When selecting the appropriate starting dose for a patient, which product is based on time to first cigarette? Okay. Oh, wow. You're fast on these. Can tell you saw a lot of tobacco cessation while on rotation. So this one is D. Yeah. So gum and lozenge, those are the ones that are based on time to first cigarette. Remember, the higher strength of 4 would be if you are smoking within the first 30 minutes of waking, and then you could start with a 2 milligram if it's beyond the first 30 minutes of waking up. Thinking that you need that higher strength if a patient is reaching for that cigarette within the first 30 minutes of waking. Okay, so some subtleties to keep in mind. Hopefully that jogged your memory a little bit. Which of the following could we recommend smokes the first cigarette within 30 minutes of waking? Ah, here we go. If you were paying attention, here's where I leaked it out. So in this case, it would be B. So this is going to be 3 only, which is 4 milligrams. So there's smoke within. We need a higher dose. All right. 2 more of these, and then we'll move into our Kahoot game. Do not eat or drink within 15 minutes before or during use of this product. And with this one, let's go ahead and end the poll here. In this case, it is actually going to be all 3 of these. It's the same for lozenge, gum, and inhaler as well, the nicotine inhaler. I think sometimes we forget about that one as an option. Okay, and then finally, which the following is true regarding the nicotine gum? Okay. In this poll, and it is all the above on this one. So chew it slowly, then park it to the peppery, tingly taste. You must use at least 9 pieces per day when starting, and then the max is 24 pieces per day. Great job. All right, now let's change it up a little bit, and we're going to go over some miscellaneous. What is the ingredient? These are just ones that you just have to know. Will they ask you every one of these? Probably not, but it's to kind of get you thinking about some of those ingredients that are not as common as what we think of when it comes to over-the-counter and preparations. And some you may have to dust off a little bit. So this is where I'm gonna stop sharing this screen, and I'm gonna go into our Kahoot game. So let's see if I can, there we go. And now the question format will follow along with what is in the slide, so you can still follow along and take notes. I did have to modify some of the questions, obviously, to fit in the Kahoot format. So pull this up here. Bear with me while I change screens here. All right, so we're gonna do let's just do classic mode. That's what I know, since we can't work in teams. All right, so it's gonna load the PIN number. So the way you'll join is on your phone device or on your computer, whichever you prefer. Type in this pin. This is always exciting. Feel free to, yeah, I'm glad to see all your all's names populate up on there. This should take us in the next 10 minutes. We'll keep it moving fast. And again, you can use your, you have the questions on your slides, so you can refer back to them. This will hopefully wake you up after we've done all those Zoom questions. Oh, I see Dr. Ramsey's playing again. He played last year, and my ad was the winner. It was not me, but see if he can win 2 years in a row. Okay. Okay. Some clever names. Yeah, let's keep it professional. Okay. All right. Is everybody in that's going to play? We'll give you a few more seconds. Get your names in. I see new ones coming in as we speak. Okay, looks like we're about 132. Yay. All right. I think that's about what we've got. Let's go ahead and get started here. A few more still coming in. All right. Let's see. Everybody wants to get in on this action. Here we go. All right. Good luck to everyone. I have to say, I don't have any prizes to give for the winner, but do your best. Check your skill sets and knowledge on this. This will be a little fun competition to see who knows these. So again, for those that know Kahoot, it seems like everyone is familiar. You want to be quick but accurate. That's where you can get the points. All right, here we go. I won't read the questions, so you can read this one yourself. All right. Zinc oxide, great. Remember, this one forms a protective layer to soothe and relieve diaper rash in common product and Desitin. So here we go. Next. So it gives our scoreboard. Garrett's doing well. Professional's doing well. Dr. Ramsey is on the board. All right. Next, OTC lice killing product. Okay. Great job. Permethrin. Remember, RID is pyrethrins, so don't get those confused with the ingredient. Okay. See how we did on the scoreboard? Dr. Ramsey in the lead. All right. Usually the ones early, though, don't maintain throughout, so from what I've seen in past Kahoot games. The early lead usually ends up falling. So let's see if that holds true. Mineral ice. See it all the time. What's the ingredient in it? Okay, menthol. Great job. So this one usually has 2% menthol. Usually it's for temporary relief of aches and pains due to arthritis and back pain. All right. Scoreboard. How are we doing? Oh, okay. Doing well. All right, here we go. Let's keep it up. Modium AD. Anti-diarrheal. The A, don't let it trick you. AD is for anti-diarrheal. Okay, we've got the scoreboard here as we can see. Dr. Ramsey's doing really good. RB, it has a streak with 4 correct answers in a row. Good to know. Okay, good job there. Here we go. Capsaicin. What's the active ingredient in capsaicin? Remember this one actively depletes substance P is how it works. So that's how we get capsaicin. And with this one, that substance P transports pain impulse to the brain. Okay, good job, everybody. Okay, let's keep it moving so we can get to our break in a few. Active ingredient of preparation H. Okay, with this one, if you said phenylephrine, you are correct. So remember, this helps relieve temporary itching and burning. Usually phenylephrine we think of in decongestants, right? But also available in preparation H. Ooh, we saw a drop, and Julia's now in the lead. Great job, Garrett's hanging in, Michaela, Emma, and Lauren. Dr. Ramsey fell off the board. Sometimes that happens. Up 33 places, BH, highest climber. Great job, BH. Dual film. What's the active ingredient in dual film? Okay, and that is salicylic acid. This is common to help you remove common warts on the hand. Okay, Julia's still in the lead. Great job. Followed by Garrett and Michaela. Let's see how we do. Keep going. Don't lose your momentum. Tenactin cream. What's the active ingredient? All right. Tolnafdate is the answer there. Remember, clotrimazole is Lotrimin. Julia's still in the lead. 3 in a row. JT is back in the game. It says, nice work. Good job, top 3, 4. Okay, let's keep it moving. I want to make sure I get you all to your break. We just got some more, a few more. Visine, max redness relief. Okay, this one's tetrahydralazine. Ooh, we've got a mix there with oxymetazoline and tetrahydralazine. This one provides symptom relief for a conjunctival edema. This might have impacted several people. Let's see. Oh, leaderboard's still good. 9 players have reached answer streak 3. Okay, let's keep going. We got one more in this section, then I've got just a series of other quick ones. Pregnancy tests. Okay, HCG is the correct answer there. All right, I know I've got like just a couple minutes. Let's keep trudging through real quickly and then we'll take our break. Which of the following would you recommend for a patient operating a motor vehicle with heavy machinery? Remember, you want to think about your sedating versus non-sedating antihistamines here. So you want something that's going to be least sedating. And that would be Claritin, less sedating. Still could a little bit, but less compared to our first generation antihistamines listed there. Okay, wow, our top 4 or 5 are hanging on. Okay. We should be done here in the next 5 minutes. Non-sedating antihistamine. So we went over which ones are non-sedating. Or is not a non-sedative, sorry. Which one is not a non-sedating? So you got to read the question carefully. Okay, ooh, flipped. Julia and Garrett, it's neck and neck. Emily is back in, answer streak 3. Good job, Emily. Okay. Flector, patch. What is that active ingredient in Flector? Okay, diclofenac. Usually this is 1 patch twice a day. Okay, Dylan moved up. Kylie's making a comeback. Okay, good job. Keep moving. I know we're going through these fast, but I want to make sure I get you to your break. Found an ally. Remember, ally used to be just a prescription medication, then slightly modified, changed the dosing. So now it's available over the counter. Orlistat. Okay, some shifting going on. Henny's back in the game. Henny. Sorry about that. All right. Another question on Orlistat. Lipases, that is correct. Okay, some shifting going on. Mandy's making a comeback. Okay, we're rounding it out here. Let's see, let's keep going. Side effect of ally. Oily stool, that is the main side effect. Okay, points racking up. Keep going. We're almost down to the last 2. Dramamine, children's syrup. Common ingredient. This is an antihistamine, prevention of nausea, vomiting, dizziness. Dimenhydrinate, easily confused with diphenhydramine or meclizine. So, oh, that was it. Oh, we're at the end. I thought we had one more. Caitlin, Lauren, the winner is it Dr. Ramsey? No, it's Garrett. Great job, everyone. All right. Nice work. Runners up, Haley and Julia. Fantastic job, everybody. You did a great job. Appreciate that. I do want to be respectful of the time. We do have a break built in. In closing on the question packet, I do have a series of questions that are related to, let me turn down the music there. I do have some common herbals that, descriptors of those. So make sure you're familiar with what those are used for. Maybe look those up in your different things and be familiar with them and various side effects that you may see with some of the herbals that are listed there. Okay. All right. And with that, I want to thank you all for your participation, your time and attention this morning. I know some of us still may not wake up yet, and I'll let you all take your break. And I know next up we have Professor Krause from Purdue University, who will be here to engage you all with some calculations and dosing.
Good morning, everybody. It's an honor for me to be here with you today, and we're going to review pharmaceutical calculations as you prepare for the Naplex. My name is Jane Krause, and I'm a faculty member at Purdue University. This is one of the courses I teach, in addition to non-sterile compounding labs and a drug abuse and addiction elective course for the students as well. I also teach a introduction to pharmacy course for the first year students here at Purdue. Congratulations to all of you. This is a super exciting time for you. You all have a very bright future, and I look forward to working with you as a profession, through the profession as a colleague. I will be with you until 12:30 today. We have a lot to get through. We'll need to be efficient when we're going through the problems. We're going to be working several problems together, about 21 problems together. I'm going to remind you of concepts, a few equations that I would suggest that you remember. So please be as efficient as you can, I guess, when we're working the problems together. If you do have questions, let me know, or put those in the chat. And then Stacy will help me monitor those as well. So we'll stop periodically to check on the questions. You did receive a link for these slides. Those were meant for you to download and keep that as a review document. So these slides are really meant as a review document for you as you prepare for Naplex. So if it's not printed, make sure that you have paper to work the problems on, or your tablet or iPad that you can work the problems on as we go. One thing I wanted to mention is wherever you end up, one thing to put on your to-do list is to become active with the state alliance or state association, wherever you are. You can do that by going to meetings. You can do that by being an active member of a committee. So there's a lot of different opportunities, and the more involved you become, the more rewarding it will be for you. So I highly recommend that you become active with the state alliance, state association, wherever you end up. After today, what I suggest is that you go back. This will help you to see what types of questions or what types of problems you'd like to review. Then you can go back to your notes maybe in those areas, or you can look for a few more problems to work in those areas. So I have provided some additional review questions to you in this document, but if you need more, just please send me an email. I'll be happy to work with you. On the Naplex, you will have something to write on. I've heard it described as laminated, like a laminated book that you can work your problems on, and then when you're done, you just turn that in. So, and there's plenty of room for you to write. So that's one thing I wanted to mention. The other thing is I've heard the majority of questions are open-ended. I've heard that you do have a mix of both multiple choice and open-ended questions, but the majority of the calculation questions are open-ended, and that is no problem. That's actually how we'll work the problems today. They will tell you, you will be told exactly how to put your answer in, and that's all you need to do. It will say, put your answer in as a whole number, or put your answer into 1 decimal point and no units. And the reason why they're doing that, it just makes it a little bit easier for them to assess it or to grade it. So just monitor how they're having you do that. For the topics that we're going to be looking at today, equivalence and conversion factors, you guys need to know those like the back of your hand. I've got those in the slide set here in a moment. Different expressions of concentration, for sure, percent and ratio strength. When I look at review guides, those are the primary expressions of concentration, but I'll remind you too about milligram percent, parts per million. Units, when you're setting up your problem, make sure you use units. That will help you with increasing the accuracy of your answer if you're canceling out units, to make sure that you use units in your setup. And then the different types of problems that we'll be reviewing. Tips with calculations. I think you know all of this, but just be respectful as you're a professional as you're a pharmacist in the profession, just be respectful. Have as much respect for calculations, I guess, is what I'm saying, because they're as important as the correct dose or the correct drug. So I think everything else on here, no trailing zeros, no negative decimal points, things that you've learned for many, many years now. When you're working a problem, though, always keep an active mind and think, does my answer make sense? So that's one thing I wanted to stress on that slide. Systems of measurement. So the metric system is very common, as you know. The apothecary system, there's a few things that we still have from the apothecary system, and that's the ounce symbol or the double squiggle. Let me just write down a few things for you here. So the double squiggle, that's the ounce symbol. This is coming from the apothecary symbol, the dram symbol, and then grain is coming from the apothecary system as well. You'll still see remnants of the apothecary system. So the ounce, the double squiggle, that's on the back of bottles. The dram symbol is how vials for tablets and capsules are sized. And then grain, I have seen problems in the review guides using grain. So it's just to be familiar with that. The system of commerce is, one thing that we get from that is the 454 grams per pound. So these are still things that we use in the pharmacy profession. The conversion factors, guys. So I just put this table in here this is a review. Please know these conversion factors. There's a couple conversion factors that we have a couple metric to pounds. So 1 kilogram, 2.2 pounds. Used with a patient's weight. That's the one that you'll see used with the patient's weight when you're changing the patient's weight from kilograms to pounds or vice versa. And 454 grams per pound, that's from the system of commerce. That's the one I just talked about. So that one you'll see used with compounding and also with purchasing or working with chemicals. So there's a couple uses of conversions, although they're all exact conversions where you'll see some of these used for sure. But do review the conversions and be familiar with those. Expressions of concentration. So percentage strength, the units are grams and mils, are grams and milliliters. And then it depends on what you're working with. If it's weight volume, it would be grams per mil. Weight or volume would be mils over mils, and weight would be gram over gram. Also remember that 50% weight volume, for example, is by definition 50 grams per 100 mils. So percent is always by the 100. Ratio strength. This is also very common. Same units, you guys, grams and milliliters. In pharmacy, that first number is when we express something as a ratio strength. In pharmacy, that first number is a 1. And then the second number is whatever it is. So, and the same weight, volume, weight, but again, the units are grams and mils. This next one, milligram percent. So this has to do with it's commonly used to denote the concentration of a drug in a biological fluid. So I just want to give you an example, 5 milligram percent. What does that mean? That means 5 milligrams per 100 mils. And this also reminds us this is equal to 5 milligrams per 1 deciliter. And a deciliter is the same thing as 100 milliliters. So I'm always reminded of that when we work with milligram percent. So milligram percent, and then parts per million. Units again are grams and mils. An example here, just to give it units, 4 parts per million. Weight volume would be 4 grams per 1 million milliliters. And that's how that's interpreted. So I want you to feel comfortable converting back and forth between the different expressions of concentration. Examples of calculations, you're not going to memorize this, but I just wanted to show you that you do know how to do a lot of these problems. This will just be a review, and these are the types of problems that we'll be reviewing today. So we're just going to jump right in with some example problems, and we're just going to work them together and start with reducing and enlarging formulas. So this is when you're given a formula. We're told that this is how much we're going to make, and then the question will ask, well, how much of a specific ingredient? How much of that do we need for the amount that we're making? Another term for these types of problems is batch formula. So you may hear that term as well, batch formula. Okay, so let's read this prescription. So with this preparation, everything's given in terms of parts. We have QSAD 12 parts, so we know that there's 12 parts total for this preparation. But if I asked you how many parts for the bismuth subcarbonate, for this very last one, for this powder, you would tell me it's 4. And mathematically, that's 12 parts total minus the 2 plus the 2 plus the 4, and that gives us 4. So another way this formula could have been written, instead of QSAD 12 parts, it could have said bismuth subcarbonate 4 parts, and we'd have the exact same thing. So the problem here, though, so we went through reading it. So let's look at the problem. It says that we're going to make 3.7 pounds, and then how many grams of that last ingredient, the bismuth subcarbonate, do we need? So this would be solved with proportions. So it's 4 parts. We just talked about how we know that. 4 parts of the bismuth subcarbonate over 12 parts total equals, and we're going to just solve for X in terms of pounds, and we'll convert to grams. We'll make sure we're answering the question at the end, over 3.7 pounds. Okay, so if we solve this, you come up with X equals 1.233 pounds. And then we double check, are we answering the question? We are not, because the question is actually asked for grams. So we'll go ahead and convert that to grams. And we're going to use 1 pound is 454 grams. And so your answer is 559.93 grams. So that is your answer for that one, 559.93. The problems on Naplex are meant to be straightforward. Do not make them harder than they are. They're meant to be straightforward for you. Okay, I'm going to go on to the next problem, which is also a reducing and enlarging formula question. And in this next one, let's look at how we're going to read the formula, and then we'll do the problem. So I put a couple things in here as a reminder. AA means of each in amount shown. The other thing you're probably noticing is we don't have any units here. So if there are no units given, if it's a solid, you will assume grams. And if it's a liquid, you would assume milliliters. Okay, so that is what we're going to do when we're reading this. So distilled water, QSAD, I'm going to put units on this now, 1,000 mils. For the powder, both powders will be in grams. AA 35, so that's 35 grams. These are solids of each in the amount shown. So this is 35 also. Okay, so there's 35 grams of each, the zinc sulfate, sulfurated potash, and then distilled water, QSAD, 1,000 mils. And then we will solve this using setting up proportions. So the question is asking for how many grams, calculate the quantity of the zinc sulfate, that very first one, right? Making sure that we knew how to read that. Calculate the amount of zinc sulfate that's needed if we make 3.5 quarts. So it's 35 grams of zinc sulfate per 1,000 mils. Set that equal to X grams over 3.5 quarts. And in this denominator, I'm just going to go ahead and convert from quarts to milliliters. So 2 pints in a quart, and then 1 pint is 473 mils. So now we have grams in the numerator on both sides, milliliters in the denominator. And if you solve for X, you come up with 115.89 grams of the zinc sulfate. So that would be the answer there. Okay, guys, on the question, do we get a conversion table? The answer is no. So I want you to be familiar with your conversions. You will also, unless they give it to you in the problem, which I think would be unusual, any types of equations, you'll need to know those as well. So thank you for that question. So this is again a batch formula, reducing and enlarging formulas, and calculating the amount you need of an ingredient based on how much you're going to make. Okay, guys, we're going to talk about specific gravity now. And what I want you to remember with specific gravity is the units are grams per mil. Specific gravity is abstract and does not have units, but in the metric system, density and specific gravity are equal, and density, the units can be grams per mil. So that's why I want you to think about the units to be grams per mil. So you can convert from grams to milliliters or mils to grams, either way. So let's look at doing this. So that's specific gravity. And let's look next at the problem where we can rule of thumb when rounding. It will tell you how many, it will tell you, first of all, how to express your answer. And I would just use the normal, unless it tells you to round to a whole number, you guys will think about how to do that, right? But I would just round with, basically round up if it's 0.5 or above, or round down if it's less than that. I think I would just use the same rule of thumb that you've been using. Although they're having you guys put in your answers as, numbers, right? Open-ended, they're going to accept more than one answer. That's how the grading is a little bit complicated, but they will definitely accept more than one right answer. And rounding is one thing that they'll take into account. Another thing is there's more than one conversion you can use, exact conversion that you can use. And sometimes the answer is slightly different, but since you used exact conversions, it's just fine. So don't worry about that. They'll accept more than one. There's more than one right answer. So specific gravity. Let's do, this is a problem involving specific gravity. And it tells us that we have 500 milligrams or 5 grams of a drug, and it's added to, we got to think about this added to right here. Because that's going to, our denominator or our total volume will be the drug plus that 1 ounce of glycerin. So that will make sense here in just a minute. This total active ingredient over total quantity or total amount equals concentration. Say X over 100 for a percent, or 1 over X for a ratio strength. Super helpful to reason through a lot of problems. Just problem solve away with that. I use that all the time. So let's think about that as we're solving this problem. So in the numerator, the total active ingredient is our 5 grams. We have 5 grams of drug. we are, and it's asking us or telling us that we're adding it to 1 fluid ounce of glycerin. We're given glycerin specific gravities of 1.25. Notice there's no units, but you know they're grams per mil. And so we're going to, and they want the percentage strength in terms of weight, so grams over grams. So we need to make sure we have grams in the denominator as well. So I'm going to start with that 1 ounce, 29.57 mils, and that's of glycerin. Okay, I'm going to multiply that times its specific gravity, 1.25 grams per mil. So now I have that in terms of grams, right? So that's, we've added it to that, plus the amount that 5 grams of drug has changed our total amount by 5 grams. So we're going to add that 5 grams to the denominator as well. So we have 5 grams of drug in a total volume of the glycerin in terms of a weight, plus the weight of the 5 grams of drug. Set that equal to X over 100. And you come up with X equals 11.92%. And this is weight. Okay. So total active ingredient over total amount. You'll be able to problem solve a lot of things just if thinking about that, giving us a concentration. Next problem is also specific gravity, you guys. So let's look at that one. And it says that if 5 pints of hydrochloric acid weighs 2.79 kilograms, they want us to calculate its specific gravity. And remember, the units that we're looking for are grams per mil, right? How many grams per mil do we have with this hydrochloric acid, 5 pints of a hydrochloric acid? So the weight that we'll put in the numerator is the 2.79 kilograms. So we're going to convert that to grams. Might as well just do that now. 1 kilogram is 1,000 grams. And then we're going to set this over our milliliters, which we have in terms of pints right now. So it's 5 pints. And then 1 pint, if I asked you how many milliliters are in a pint, you would tell me 473 mils. And you come up with 1.1797. The units are grams per mil, specific gravity, the units for that. Now, if I were going to round this, if they said take it to 2 units to the right, 2 decimal points, I would say 1.18, and that's the specific gravity for that one. All right, guys, I'm just going to go on to the next one, which I have labeled as a dosage calculation. And this is involving ratio strength and epinephrine. So epinephrine is a drug that's often dosed in terms of a ratio strength. Anytime you see a medication dosed in terms of ratio strength, that means that that medication is super powerful and it doesn't take a lot for the effect. So we want to be careful and 100% accurate with all our calculations, but this one, you want to be super accurate with this one. Okay, so we have in an emergency situation, 400 micrograms of epinephrine are ordered to be given. And the way that we have it available to us is a 1 to 10,000 weight volume. So 1 gram and 10,000 mils. I think that's key. Just always remember with ratio strength, what the units are grams and milliliters, depending on what we're working with. So how many mils of the injection are needed? So I would solve this with canceling units. That's one way to do it. So it's 400 micrograms. That's the order that we got. We are going to convert this. I convert to milligrams and then I'll convert it to grams. So 1,000 micrograms per milligram. And then again, 1,000 milligrams per gram. Now I'm going to bring in that 1 to 10,000. So it's 1 gram per 10,000 milliliters. And you come up with 4 milliliters for the answer. So that on this one, they probably say give your answer as a whole number is my guess on that one. So let's see what we've got coming up here, guys. We've got, okay, I called it application of conversion. So let's see what we got. So we have, okay, we have a cough syrup that contains 10 grains, guys. That's not gram, that's grains. 10 grains. And how many milligrams are contained in 10 milliliters? So what we're solving for, how many milligrams? We're solving for milligrams. 10 grains of active ingredient. And we need to convert grains to milligrams. And there's a couple different conversions. Either one would be fine. I'm going to use the one that gets me there a little bit quicker, 64.8 milligrams per grain. So now I have it in terms of milligrams. This is in a volume of 1 fluid ounce. 1 fluid ounce. And a fluid ounce, exact conversion, 29.57 mils. And I'm going to set that equal to, they're asking us in 10 milliliters, how many milligrams do we have? So we've got milligrams in the numerator, milliliters in the denominator. It could have also said how many milligrams are contained in 2 teaspoonfuls. Same thing, right? 10 milliliters. So there's just more than one way to write these problems. And when you do this, it's 219.14 milligrams. Again, guys, the conversions or the calculations are meant to be straightforward. All I want you to do is practice before you go in. That will give you confidence and you'll all do great. See what we've got coming up. All right, altering product strength by dilution or concentration. So what we're doing it with some problems is we have active ingredient and it's in a certain volume. And we're going to dilute it by adding something to that does not have active ingredient in it. So we would expect the concentration to go down, right? We're adding diluent, we're increasing the volume, the concentration would go down. So there is a equation. Well, I've got 2 of these problems. This problem I'll show you with this equation. Some students really like this equation. The other one, we're just going to reason through it. If you don't like to memorize equations and you don't memorize ones, you really don't have to. There's a way just to problem solve these 2. So quantity times strength equals quantity times strength. This is only true, this is an equation you can use if the active ingredient is not changing, okay? So that's how I write that, just as a reminder to myself and just as a check. Is the amount of active ingredient changing? And it is not. We have 400 mils and it's 20% of a drug, unknown drug. It's 20% and it's being diluted to 2 liters. We're not adding any more active ingredient. What would be the percentage strength that results? So in this case, you would just substitute in. So the quantity, 400 mils, strength or concentration. Think of the strength as the concentration, 20%, equals 2,000 mils times the strength. And that's what we're asked to solve for. What percentage strength do we get? And if you look at this, you get 4%. So you're thinking, does this make sense? And it does. This is an inverse relationship. The volume went from 400 mils to 2,000, so it increased. the percent then of the active ingredient went from 20% to 4%, it decreased. There's an inverse relationship with these. Okay, this equation, quantity times concentration equals quantity times concentration, or quantity times strength equals quantity times strength, cannot be used if you're adding active ingredient. Okay, so just do a double check. Always that, is the active ingredient staying the same? Okay, on the Naplex, do we use the approximate or actual number for the conversion? You would use the exact conversions, just how we're doing that today. Just how we're doing it today. Okay. So, all right, guys, let's do one very similar to this, but we're just going to reason through it. Thank you for your questions, by the way. Okay, dilution and concentration. Okay, here's another one. How many mils of water should be added to 300 mils of a 1 to 750 weight volume solution to make a 1 to 2,500 weight volume solution? So I would consider this dilution concentration. You could solve with quantity times strength equals quantity times strength, but let's just reason through. Let's just reason through and think about, let's calculate the amount of active ingredient. Let's calculate then what volume it needs to be in to give us that strength of 1 to 2,500. So we have our source of active ingredient is at 300 milliliters. And 300 milliliters, the strength is 1 over 750, or 1 gram per 750 mils. Okay, and if you solve this, you get 0.4 grams. I'm going to just say that's the active ingredient, 0.4 grams of active ingredient. That is not changing. The volume that it will be in is what's changing. So 0.4 grams. And what volume, I'm just going to call that X for now. And what volume does that need to be in to give us that 1 to 2,500 ratio strength, to give us 1 gram per 2,500 mils? Okay, so if you solve for X, you get 1,000 mils. And then at this point, you want to double check, have we answered the question? So that amount of active ingredient needs to be in 1,000 mils. But the question is, how many mils of water do we need to add to 300 mils? So it's in 300 mils already. So the amount of water, we need one more step here, is 1,000 mils minus that 300 mils. It gives us 700 mils of water. So that's another thing I want you to do, is just always go back and make sure you're answering the question. Make sure you're giving them the units that they want as well. Because if you do not give them the right units, that will be that, yeah, need to give them the units they're asking for. Okay, so be sure you're answering the question. Okay, guys. The next problem I have is a stock solution problem. And these are the ones, if I had you in class, these are the ones that I say you work backwards. So we're going to do one of these. It will be a good review, and you may or may not see a stock solution problem, but I do want to review this so that you're familiar with this. So we have benzalkonium chloride solution, 240 mils. It says to make a solution. So this would be a concentrated solution that would be given to the patient, and then they dilute it to use it. So the patient would take 10 mils, or it could have said 2 teaspoonfuls. They're going to dilute it to a pint to use it. Okay. And so we are going to calculate how much benzalkonium chloride we need for this preparation. Make a solution such that it's 10 mils diluted to a pint gives us 1 to 4,000. So what I do is I write off to the side. It helps me to kind of see what we're doing here. 10 mils. They're going to take 10 mils. They're going to dilute it to a pint, or 473 mils. And that is 1 to 4,000. Okay. So this is the information we want to work with. That's where we want to start. Okay, we can calculate the amount of active ingredient in that pint. So we would start by the 473 mils. And it's 1 gram per 4,000 mils. Just, it tells us that right above. And I'm going to take this out to several units to the right of the decimal because I'm going to try not to enter, and excuse me, guys, 0 point, yeah, there's a point right here, 0.11825 grams. Okay, 0.11825 grams is what you calculated. So in that 473 mils, once it's diluted, we have that much active ingredient. That amount of active ingredient is also in this 10 milliliters. It's also in that because that's where it came from. We didn't add any active ingredient. So I can write down what I know. I know that I have 0.11825 grams in 10 mils. Okay. Now this is, we're almost there. We almost have it solved now. Every time, it's a 240 mil bottle, right? We have 240 mils. Every time the patient takes out 10 mils, every time you take out 10 mils, you have this amount of drug, 0.11825 grams. So in 240 mils, we would need how many grams? Just set that equal to X over 240 mils. So in that 240 mil bottle, I will have 2.838 grams of benzalkonium chloride. You guys see that I take my answers out to several units to the right of the decimal till I get done and express the answer however they want it expressed. So I take it out to several units. Now, this is a case where we're going to say, have we answered the question? The question is, okay, we need that many grams of benzalkonium chloride. The question is saying how many mils of a 17% stock solution of benzalkonium chloride do we need to use to prepare this? In other words, this is telling us our source, we do not have pure crystals of benzalkonium chloride. We have a 17% solution or stock solution available to us. How many mils of that do we need to give us that amount of drug? So we have one more step, and it's at 2.838 grams of the benzalkonium chloride. And how many mils of 17%? So 17, I'm putting units with 17%, 17 grams of benzalkonium chloride per 100 mils. And if you do this, you will come up with 16.69 mils. So you would take 16.69 mils of that 17% stock solution, dilute it to 240 mils, and you have it. Now, when you take out 10 mils and it's diluted to a pint, you get the 1 to 4,000. So again, the ones you work backwards. So I just wanted to just review one of these with you and how to solve those, how to approach that. All right, we're coming up on allegation. Allegation is a method. Allegation is the ones with the lines. So we're going to do a couple. We're going to talk about allegation, and then we're going to allegation alternate, by the way. And we're going to start with that, and then we're going to do a problem. So let's just look at the next diagram. So allegation alternate. What this is saying is we need 10% of something. We need 10% of, I'm going to just use benzalkonium chloride again. We need 10% of benzalkonium chloride, but we don't have it. What we do have, we have 20% and we have 6%. So this is a method, guys. This is a method to solve in what proportions do we mix the 20% and 6% to come up with 10%. So we have 3 columns. The first column is percent that you have. The second column is the percent that you desire, and the third column is parts. Okay. In the first column, the percents that you have, you would list those high to low. So we have 20%, oh, we have 6%, benzalkonium chloride. Middle column is what you want 10%. Then you would take the differences diagonally. So you have 20 minus 10 gives us 10. 6 from 10 gives us 4. So you're taking the differences diagonally, and then you read it straight across. So four parts of the 20% mixed with 10 parts of the 6% will give us 10%. So now you've got it set up, and then you would solve with proportions using information they've given you in the problem. Okay. A couple things with alligation. If you're solving a problem with alligation, I think it's a lovely method for certain problems. Double check the first column and the percents that you have and the percent you desire. Those percents have to refer to the same thing. They have to all refer to benzalkonium chloride, or they have to all refer to sodium chloride. They have to all refer to the same thing. The first column, like I said, you list those high to low, 20 and 6. That's how we have those listed. The middle column just does a double check. That middle column numerically has to fall between 20 and 6. If it doesn't, you've set up something wrong and you want to go back and fix that. Okay. If I had, for example, 30 in the middle column, that doesn't fall between 20 and 6. And I would go back to look at the problem and see what I've done incorrectly, because what you're saying is it needs to, I can get 10%, I can come up with 10% mixing 20 and 6, but I could never come up with 30% mixing 20 and 6%. Okay, so those just are double check that the percents all refer to the same thing, and that middle column falls between the numbers numerically. So let's apply this. Let's solve a problem using alligation. Okay, and this is one with two strings. So we're going to use alligation as alligation alternate, and I'm going to do my 3 columns: percents you have, percent you desire, and parts. Okay, now let's see what we got to fill this in. How many grams of salicylic acid should be added to 75 grams of a polyethylene glycol ointment? Salicylic acid isn't mentioned there at all. To prepare an ointment containing 6% weight, grams over grams salicylic acid. So we are mixing grams of salicylic acid that is pure salicylic acid. You can assume that unless they tell you differently. So that's 100%. That's our salicylic acid. That's how we're representing that on this chart. We're mixing that with 75 grams of an ointment base that doesn't have salicylic acid in it. So that's 0% salicylic acid. And we want to come up with 6% salicylic acid. So let's double check. Do all the percents refer to salicylic acid? We have pure salicylic acid, so that's on here as 100% in the first column. We have an ointment base that we're mixing it with that has no salicylic acid right now. So that is 0% salicylic acid. And we want 6% salicylic acid. So everything checks out there. The other thing is that the number 6 does fall between 1 and 0. I'm going to take the numbers, take the differences diagonally. Then I get 94 here, and 0 from 6 is 6. And then you look to see what information do they give me to work with. We know that we have 75 grams, and I'm going to just put it over here, because this is 94 parts of the ointment base, and we have 75 grams of that. And the question is, how many grams of salicylic acid do we need? So this is question mark grams. So that's setting up the problem and then looking to see what we have to solve for and what information do they give us to work with to set up these proportions. So now it's 94 parts is to 75 grams. I hope this is all coming back to you guys, equals 6 parts over X grams, and X equals 4.79 grams. Okay. So that's using alligation to solve this problem. So you would take 4.79 grams of that salicylic acid, pure salicylic acid, and incorporate that into the ointment base that you have, that 75 grams, and you would end up with a 6% weight salicylic acid ointment. Okay. All right. Good. Alligation. There's also an alligation medial. So that's what I want to go to next. So there's alligation alternate, which is what we just did, alligation medial. So we'll head on over to alligation medial. Alligation medial, you guys, is a weighted average. And it's really how we've approached many of these problems already, where we talk about total active ingredient, how much active ingredient we have, and in what volume or total quantity or total amount, however you want to say that, and what quantity. And you can set that equal to you can set that equal to X over 100 for a percent, 1 over X for a ratio strength. So you can reason through, guys, many problems just using alligation medial. And we've already been doing that. Semester GPA is an example of alligation medial or a weighted average. Okay, so that's really the concept where that's coming from. So let's use this. Let's use this now that we have this name with it, and we're going to solve a problem with alligation medial. So with alligation medial, and it's volume, so mils over mils. So always think about what units you're working with. So calculate the percentage of alcohol, volume in mils over mils, in a lotion containing, okay, it sounds like we're mixing together some stuff, and they want to know what the finished concentration will be. No problem. We have 2 liters of witch hazel, which is 14% alcohol. So we want to really pay attention to the alcohol. That's our active ingredient. 1 liter of alcohol, that's 95%. And then enough boric acid to make 5 liters. So that last one that we're mixing it with, that boric acid, has no alcohol in it. But the way it's written, enough boric acid to make, that tells us right there that our denominator, our total quantity, is 5 liters. The way it's written, enough boric acid to make 5 liters. So again, guys, we're thinking total active ingredient over total quantity. Okay, and in this case, because we're solving for a percent, we're going to set it equal to X over 100. Active ingredient is alcohol. How much alcohol do we have? Well, let's calculate that, and we'll start with the 2 liters. In that 2 liters, or 2,000, 2 liters, we're going to change that to 1 liter is 1,000 milliliters. The percent alcohol is 14, or 14 mils of alcohol per 100 mils. And we come up with 280 mils of alcohol. So that's part of our numerator. The other part is that 95%, and we have 1 liter of 95%. 1 liter is 1,000 milliliters. We have 95% or 95 mils of alcohol per 100 mils. And that is 950 mils of alcohol. And we've already talked about this, but the boric acid, there is no alcohol in that. They would tell us if there was. There is no alcohol in that in the denominator, but it does tell us that the denominator is nice and easy, and it's 5 liters. So our numerator, total active ingredient, is that 280 mils plus the 950 mils. That's the amount of alcohol we have over, love it, 5,000 milliliters. Okay. We're setting this equal to X over 100. Solve for X, and you get 24.6%. Total active ingredient over total amount. Weighted average, allegation medial. Okay, calculations with parenterals, flow rates. I did see a lot of, in review guides that I look at, a lot of questions with flow rates. So, and just no problem, you can do these, but just make sure that you answer however they want you to indicate the flow rate, drops per minute, mils per minute, certain amount of drug per hour, whatever they tell you. The other thing I want you to think about or remember is that the amount, the volume that we're working with is the amount of drug, for example, 10 milliliters, that you've added to an IV bag. Maybe the IV bag is 100 mils, then the volume that you work with is 110 mils. So let me just write that out. 10 mils of drug, this is just, excuse me, 10 mils, not milligrams. So mils of drug that you're adding to a bag, 100 mil, this is something that's not premixed, that's being prepared. 100 mil bag gives 110 mils. And that's what would be used in the calculation, especially if it's a flow rate, that's the volume you're working with, or maybe a concentration. Okay, so we'll do some problems, but I just wanted to remind you that we all need to agree on that. Okay, so let's do a problem with parenterals now. So we have an order for a child, and it's dosed at 1 milligram per kilogram per hour by IV injection, and it's if 10 mils of a 25 milligram per mil solution of the drug is added to a 100 mil bag, D5W, what should be the rate of delivery in mils per hour? So we want mils per hour. I'm just going to write that out just so we remember what we're shooting for, mils per hour. I want to start with that, with the amount of drug. Let's calculate that. We have 10 mils. It says 10 mils of drug, and it's 25 milligrams per mil. That gives us 250 milligrams of aminophylline. Okay, that is in a volume of 110 mils. That's exactly what we just talked about. It's the 100 mil bag, and we've added 10 mils to it, so it's 110 mils. Okay, so we wrote that out. We just want to remember that. Now we're going to do the problem starting with the weight of the patient. We're going to just cancel units. It's a 40-pound child. To convert the weight to kilograms, we use the 2.2 pounds per kilogram conversion. So now we have the weight of the child in kilograms. The order is for 1 milligram per kilogram per hour. Okay, so we've got milligrams per hour right now, right? Milligrams per hour. and we want to get to milliliters per hour, I'm going to incorporate what we just talked about above, which is that 110 mils. In that 110 mils, we have 250 milligrams of the drug. Okay, so if you solve this, you get 8 mils per hour. Okay. We get mils per hour. All right. Guys, I'm going to go on to the next problem, and we're going to just take a break for a second here. Instead of writing out questions, there are sometimes word questions that are related to calculations. So this was one that I found. So I just wanted to talk through this with you and how you would approach it. And you guys probably have it already answered. So parenteral products such as half normal saline solution with an osmotic pressure less than that of blood are referred to as what? So I would, and I think this is again a straightforward question, but I would eliminate the ones that I know are incorrect. So I'm just going to mark those off. So if it's equal to blood, we know that's isotonic. So we know it's not isotonic. And isoosmotic and neutral sound pretty much the same as that, as isotonic. So now we have it down to hypotonic or hypertonic, and it's half normal saline, less than that of blood, so it's hypotonic. So there you go. I hope you get that question on Naplex. So let's see what we've got. Okay, we're going. This is our lead into isotonic problems. So let's do one of those. Isotonic calculations. Okay, so just a little bit of a reminder about a solution that has the same tone or the same osmotic pressure as the biological fluid with which it is to be mixed is generally equivalent to 0.9% sodium chloride. Sodium chloride equivalent. So if you have a problem and you need the sodium chloride equivalent, they will give that to you. That is not anything you would be expected to memorize. Oh my goodness. Or it might be abbreviated as an SCE or an E value, sodium chloride equivalent. So here's an example. If the drug is phenylephrine, the sodium chloride value, SCE value is 0.32 grams of sodium chloride per 1 gram of the drug. So my big takeaway here are the units. The units on the sodium chloride equivalent, so will help you greatly to solve these, is gram of sodium chloride per 1 gram of the drug. Okay. So that's my takeaway, or that's what I wanted you to think about. Grams of sodium chloride per 1 gram of the drug. Next page, guys, has a lot of writing on it, but I'm going to talk you through it in about 15 seconds. These are the steps with isotonic calculations. And if you just, in your mind, if I'm just going to remind you what these are, then you can solve these for sure. Step 1 and 2, I'm going to put together, but steps 1 and 2, what this is this is a preparation. Maybe it's nose drops, or maybe it's eye drops that are being prepared, but they need to be made isotonic so that they're comfortable for the patient to use. They are not going to be isotonic without adding something to it. No, they're hypotonic. So in the preparation, the formula, the first thing you would do is calculate the quantity of each ingredient in terms of grams. We're going to do a problem, guys, so just listen to this. This is the quantity of each ingredient in terms of grams. You would multiply that by each of them by their sodium chloride equivalent to see how much they're adding, how much each ingredient is adding to the isotonicity of the product. And you will come up with grams of sodium chloride that you have. So with these 2 steps, you get grams of sodium chloride that you have. The third question, the third step is based on the quantity that you're making, 30 mils, for example, multiply that times 0.9%. That gives us the grams of sodium chloride that we need. You'll see that 3 is greater than what you just calculated in steps 1 and 2. And so that will tell us, that's this step right here. You take the difference and you come up with grams of sodium chloride to add. And then the fourth step, or the fifth step, excuse me, is if you're not making it isotonic with sodium chloride or you're making it isotonic with maybe boric acid, maybe dextrose, then you would do one more step. But the example we're going to do will stop at that fourth step. So those are the steps. Let's do a problem. All right. And for some reason I have answers here. Just in case, guys, you see some of these, we'll work one of these. So what weight of sodium chloride, and it doesn't tell us, but we can look at answers to see. It'll either be milligrams, grams, or micrograms, one of those three, of sodium chloride should be used in compounding the following preparation. And they give us a formula weight, they give us a dissociation factor, and they give us the sodium chloride equivalent. That we know we need. These other things we don't need. It's just extra information, no problem. You guys got that. They've given us extra info. You can just ignore that. So we have let's do steps 1 and 2. So steps 1 and 2. We have 0.25 grams of ephedrine. It's the only active ingredient because the sodium chloride QS is us calculating the amount of sodium chloride to add to this to make it isotonic. So we have 0.25 grams of ephedrine sulfate. I'm going to abbreviate that. We're going to multiply that times its sodium chloride equivalent, 0.23, and it's grams of sodium chloride. We talked about the units over grams of drug, in this case, ephedrine sulfate, and you come up with 0.0575 grams of sodium chloride that you have. Okay, that's what we have. That's how much that preparation is contributing to the isotonicity. Step 3 tells us, based on the volume, based on that 30 milliliters, how much sodium chloride do we need? So we multiply it by that 0.9% or 0.9 grams of sodium chloride per 100 mils. And you come up with 0.27 grams of sodium chloride needed. Okay. Then the fourth step then is to just take that difference. So we need 0.27 grams. We don't have that. So what's the difference? How much do we need to add? 0.27 grams minus what we calculated with steps 1 and 2, 0.0575 grams. And you come up with 0.2125 grams. That is the answer. Then in this case, we would look over at our answers and say, do any of these equivalent? And that's 0.2125 grams. If you convert it to milligrams, you come up with 212.5 milligrams. So you'd move it over 212.5 milligrams, which I think we have as an answer, or C. The isotonic calculation. Okay. All right. Let's see what we got. Okay. Guys, I just threw this in there because as I was looking through review documents, I saw that sometimes they converted from centigrade to Celsius or Fahrenheit to Celsius, or vice versa. So I've just got those in here. I've got those so you can look at, I just put those equations in there. I also have these I want you to know because I think you're gonna see some kind of calculation where you need to calculate milliequivalents. And this is something that you've done, that you guys did when you were in chemistry, right? So it's been a while, but they will usually give the molecular weight and they'll usually give the valence to you to solve these. So then it's what it is just knowing the equation and filling in the numbers, and we're going to do a problem in just a moment. This is the same equation, it's just reversed a little bit. So I would just suggest knowing one of these equations so that you can solve your question if you get one of these. The valence, just so you know, is the absolute value of the total cation or the anion that for the chemical that you're working with. So that's what that is. But let's do one. So we'll put this equation to use here. Okay, so conversion of milliequivalents to milligrams. So a woman has a prescription for 32 milliequivalents of potassium chloride by mouth. The pharmacy has 600 milligram KCl controlled release tablets. How many tablets does she need to take each day to provide this dose? And they are giving us the molecular weight. They did not give us the valence, but the valence is 1. Okay, I'm going to just write that on here. Valence is 1. Okay, so the equation, I'm going to write it out. Milligrams equals milliequivalents times the molecular weight. I'm just going to abbreviate that as MW over the valence. So milligrams equals 32 milliequivalents times 74.5 divided by the valence of 1. 2384 milligrams. And now they said we have 600 milligram tablets. So let's incorporate that. 600 milligrams per tab. And you come up with 3.97 or 4 tablets would be the answer here. So the valence you would assume is 1. Okay, there's a valence of 1 for the potassium chloride. It's the absolute value of the cation or the anion. Okay, the absolute value. I've seen them usually where they give you the valence. Okay, but in this case with potassium chloride, the valence is 1. So again, have this in your back pocket, this equation, and those milliequivalent problems will be no problem at all. All right. I just for completeness, I put in these equations, and I wanted to tell you guys that you guys are the experts right now. Absolutely. With all of these equations that we're coming up to. So I'm not putting in problems, but you guys know, I just wanted to put them in here for completeness into your study document. So body surface area where the units are square meters. I think knowing units is like key, like it's super important. So square, if you have to calculate something, I think that always helps. And then the other thing to remember is that 1.73 number. 1.73 square meters is the body surface area for an average adult. So that helps you just double check your answer. When you're at the end of every calculation, you're thinking, does my answer make sense? So you're keeping an active mind, and you would think about what you would expect the number to be, keeping in mind the average body surface area 1.73. Okay. The other thing that I gave you on the next slide is I gave you the average body surface area values in addition to that 1.73. This is just a reminder. Do not memorize this. You do not need to memorize this. But my point with this is all of these numbers are very small. These are all very small numbers. So be super careful with your calculations. And if you're calculating a body surface area and you get a number such as 5, or you get a number like 10, then you know you need to recalculate because these numbers are very small and they're actually very close to each other. So that's my takeaway with that. Body mass index based on height and weight. This is the clinical standard for determining excessive weight and obesity. The units are generally expressed without units, absolutely. But I want you to know the units are kilogram over square meter for the body mass index. And then there's a couple equations here that I know that you're used to using. So just again, a reminder of calculating body mass index and knowing the equations. Body mass index categories are given here as a reminder. And then ideal body weight and creatinine clearance. You guys really, really, really are the experts here. You guys have been doing this forever. But again, I included this for completeness. And you do need to know these equations. So how to calculate the ideal body weight for a male and a female, and then also the creatinine clearance. Okay. So this one, guys, you all know. So creatinine clearance, this was a question out of a review guide, may be calculated from serum creatinine by using this one right here, number A. I know that you guys know that. Got one more question coming up, more like a multiple choice question. And it says, based on Mr. Green's height and weight, he has a BMI of approximately 30. Which of the following statements apply to a situation? So if you get something like this, you just kind of treat these all as true false. So body mass index or BMI stands for basal metabolic index. That is false. I would just treat all these as true false and see what I end up with. The units are of our square meters. That is wrong. We just talked about that. It's kilogram over square meters. So that's actually false. And as BMI meets the definition of obesity. So that one's the true one. So it would be B right here, 3 on. Okay. All right, guys, you guys, we are doing really, really amazingly good with time. We might even, believe it or not, end slightly early. We'll just see. That never happens, but we'll just see. So the next part, guys. Whoa, I have another question for you. Okay, this is another word question. I think it might be a little bit hard, but the answer is correlates with cardiac output. The rest of the other ones are all false. So you could just take that answer. So yeah. Okay. Pharmacokinetics. Basic pharmacokinetics. Guys, I believe that Darren talked about this, but you'll have access to what they call a 5-function calculator. Add, subtract, multiply, divide, and also square root. So a 5-function calculator. You're not going to be doing complicated pharmacokinetics calculations, okay? But you will be expected to do some basic kinetics information. So the pharmaceutical calculations book that I teach from has information in there on basic kinetics. And I took this information out of that book, and just a reminder of some of the equations that you probably saw when you took kinetics. So these are just selected bioavailability and kinetics calculations. And like I said, the calculations dealing with kinetics will be straightforward due to the excess of the calculator that you're using. But I do suggest knowing these equations and concepts, and they're also consistent with the problems that I've seen in review guides. So the bioavailability factor, or F, the volume of distribution. So the part of that bioavailability factor is changing a drug, the dose of a drug from IV to PO, or changing the route of a drug. And I did see questions like that with in the review guide. So a lot of times you are given the ratio that you do it, 1-to-1 or 1-to-2 or whatever it is. If you're not given that information, the bioavailability factor is another way to solve that. Volume of distribution, and then the elimination rate constant and the half-life. So these are not problem solving things. I don't feel this is really just knowing these equations and filling in the information. So I wanted to put this into the document, and we do have time to do a few problems with these equations. So we'll do that. So we'll go on to this first one. So it says the area under the curve for an oral dose of a drug is 4.5 micrograms per mil per hour. And for an IV dose is 11.2 micrograms per mils per hour. What is the bioavailability of an oral dose of this drug? Indicate your answer as a percentage. So the equation that we're thinking of is that bioavailability factor equals area under the curve for oral over area under the curve for the IV. So we're just going to plug in the values that are given to us, guys. That 4.5 micrograms per mil per hour over the area under the curve for the IV, or 11.2 micrograms. Double check that we've got the same units, right? Numerator and denominator. And you come up with 0.4 or 40%. Answer for that one. So again, knowing those few basic kinetic equations and how to apply the information. So second one, volume of distribution, the plasma concentration or the blood concentration, the amount of drug over the volume of distribution. So that's the one that you would immediately think of, right? When you're asked to calculate the volume of distribution, and usually volume of distributions are given in liters, and that's what they've asked it for. So a 6 milligram dose is administered IV and produces a blood concentration of 0.4 micrograms per mil. What is its volume of distribution in terms of liters? So you'll just, the only thing we have to do, we're going to plug in the information, then we do need to convert the units, right? The units that we're working with to make sure that we can come up with mils, or liters, excuse me. So we have 0.4 micrograms per mil equals, this is 6 milligrams per volume of distribution, and we'd like that in terms of milliliter, or liters, excuse me. So 0.4 micrograms per mil. I'm going to go ahead and convert 1,000 mils per liter. And I'm also going to convert the micrograms to milligrams, so we agree on both sides of the equation. So that equals 6 milligrams per volume of distribution. So now we just solve for the volume of distribution, and you come up with 15 liters. And I've got one more, guys, involving the half-life and also the elimination rate constant. So automatically you're going to say, okay, it's T1/2 equals 0.693 divided by the elimination constant. So here we go. So it says The elimination rate constant for a drug is 0.58 hours to the -1. What is the half-life in terms of hours? So we're just going to plug in our numbers. So T1 half equals 0.693 divided by 0.58 hours, and solve for the half-life, comes up to 1.19 hours. Okay, so at Purdue, I teach the non-sterile compounding labs, and the USP 795 is the non-sterile compounding chapter. So that's my favorite USP chapter, chapter 795. And I wanted to incorporate beyond use states. I wanted to remind you of the beyond use states, because this has been a long time since we did it, since I did this with the students. So let me just talk you through this just as a reminder. What also is kind of interesting is that the 2014 chapter is still the current chapter. So in 2019, okay, pre-pandemic, they started to work on revisions, but they were not accepted immediately. Then we went into the pandemic, and now we still don't have agreement on the updates, okay, or the revisions for the chapter 795. When we do have the new chapter, when that is published, there will be changes to the beyond use state, and they'll be fairly significant. But for you guys, this is the current information, okay? And these, the chapter offers guidelines and enforceable set of standards describing procedures and requirements for non-sterile compounding, and then state boards of pharmacy are responsible for enforcing those standards with the intent to protect patients and pharmacists. So beyond use state should be included on all compounded preparations, and it's defined as the date after which a compounded preparation is not to be used. A beyond use date is not the same as an expiration date. Okay, that applies, expiration date applies to commercially manufactured products, and those are generally expressed in terms of years, expiration date. A beyond use date, this is what we need to think about when we're deciding what category it falls into and what kind of beyond use date we're going to assign. It depends on whether the preparation contains water. Either there's water in one of the ingredients or we're adding water to it. The expiration date of each ingredient, that's key, because the beyond use date can't be after an expiration date of one of the ingredients. So that's something we need to think about. Storage temperature, and whether there are references already documenting the stability of the preparation. Then we don't need to go through this. Okay, so let's see what they are. Just a reminder. So here are our options. Okay, 14 days, 30 days, and 6 months. 14 days for water containing oral preparations. Okay, this means that there was water in one of the ingredients, or in the compounding process, we've added water. Stored at controlled cold, it needs to be stored in at a controlled cold temperature, but the beyond use date is no longer than 14 days or the earliest expiration date of the ingredient. Right now, there is no standard on what day one is. Is day one the day we compounded, or is day one the next day? So what I do at Purdue is I accept both. So just know that, guys, just know that this is still what's being used. And that is one thing that they're changing. Day one likely will be the day that it's compounded. Although that's not a full day, that would be considered day one. But right now, we don't have that information. Okay. Second one is water containing topical dermal mucosal liquid stored at controlled room temperature no later than 30 days. So 30 days from the day it was compounded or the earliest expiration date of any ingredient. If by chance one of the ingredients that was used in the compounding expires before that 30 days, we have to use that as our beyond use date. And then the next one, 6 months, is a non-aqueous. So no water is present or added, and it's stored at controlled room temperature. At Purdue, one of the first things we compound is a powder. And that was a 6 month. That has a 6 month beyond use date, or the earliest date of any ingredient. So that's the beyond use date. Okay. All right, guys. I have 12 additional problems that I've given you to do in your free time, which I know you don't have, but as you're preparing for the Naplex, I've given you 12 additional problems. And also I've given you the answers to those. So so again, these slides are a packet, right? A packet for you to use. So, Stacy, I want to talk to you. I think I'm done. I want to just say a couple more things to the students, but I got done quite early.
Wow, that's great.
Okay.
Does anyone have any other questions they want to put in the chat
If you
that we did not answer?
So while you guys are thinking about that, I just want to say that I look forward to working with you through the profession. I think I've already said that, but I wanted to say it again. Please email me. If you don't have questions right now, that's absolutely fine. But as you're working on things or going through problems, email me if you come across any questions that you have. I know that you'll all do a great job. I do want you to practice just for confidence and do know the conversions, do know some of those equations that we talked about. And then congratulations again, this is a super exciting time for you. And there might be a question. Okay, yeah. So the scrap paper question, Stacy?
Yeah,
okay.
That's the only other one I saw come in.
Yeah, so the scrap paper, how it's been described to me by recent graduates that have taken Naplex, they are given like a booklet with laminated pages in it, with plenty of pages and plenty of room to write. So you would, for all of anything you want to write down, even on non-calculation stuff, if you want to write down something that you know, write down things you know, just to help you answer the question. You have plenty of room for that. Laminated booklet, laminated pages, similar to a whiteboard, and then you just turn that in when you're done with the exam. So you'll have enough room, absolutely. It's yes, it would be like a dry erase marker on these laminated pages that you would use. Yes, that's right. Very good.
And then do we need to know valences or numbers of particles for substances?
Sometimes the ones that I've seen, and that will be a quick review, right, for you guys to remember valences, but sometimes I've seen them given in the problems and sometimes not. So I've seen it both ways. So be familiar with valence. Let's just say that, which I think you guys are. Okay. All right. Anything else? If not, you've got my email and please contact me with whatever questions you have as you're preparing, and good luck. And again, I know you'll do well.
Well, thank you everyone for joining. For those of you who don't know me, my name is Dr. Janelle Rogers, and I'm a faculty member at Purdue University. And then I practice as an internal medicine pharmacist at the hospital at IU Arnett Hospital in Lafayette, Indiana. So kind of my goal for today is to do approaches to solving patient-based problems, or just kind of solving problems in general, really focusing on the top 200 prescription drugs. And it's going to be a mix of different type of questions. So we'll have things like brand to generic, drug-drug interactions, side effects, contraindications. You know, there's also dosing, clinical decision-making. And a lot of times those things are just kind of mixed in throughout. One thing I will say, so I did this last year as well, and I know some people were hoping that instead of just kind of going through practice problems, it was going to be more of like a review of what you need to know for the Naplex. And in 2 hours, that's just not possible. It's kind of like taking 4 years of knowledge and condensing it down to 2 hours, which I can't do. So I'm just going to do some practice problems for you, which will hopefully at least give you an idea of areas to focus on. So if you find that, you know, you're having trouble with brand to generic, maybe focus there, or drug interactions, or certain topics that you're having trouble with. I tried to vary it a little bit, but it's just kind of a small piece of examples of questions that you might see. So obviously there's a lot of other questions. Chances are these questions won't be the ones that you see on the Naplex. It's just to kind of give you an idea of it. I actually did have to take the Naplex myself 6 years ago. So I moved here to the US from Canada. So that was where I was originally licensed and practicing. So it hasn't been that long since I took it. I was, I believe, in the last group of people to take the old format of the test. So I've heard it's more, you know, case-based problems now. But I think I can still hopefully give you an idea of the types of questions that you might see. A couple of tips as you're solving, especially like the case-based problems. This is one that I am often guilty of. When there's a really long case, read what the question that they're asking you is first before you read the whole case. So sometimes I read a case and I'm already thinking about all of the things that, you know, might be wrong with it or that I might want to fix. And I'm thinking about renal function and dose adjustments. And then the problem or the question itself might just be asking for like a brand to generic. And then you're going to waste all of that time really going through the case. But if you kind of start with the problem, then you know what to focus in on as you're reading through the whole case, especially if it's a long one. Another tip for you is just to read the question very carefully. So especially kind of sneaky words like every, never, always, can make a difference. So just kind of make sure you know exactly what they're asking of you and you're not answering a different question. And then what I like to do is to try to come up with my own answer before I actually look at theirs, because sometimes there's some distractors in the questions that, you know, you might want to pick them for different reasons, but if you already have your answer in mind, that will help you, you know, if you see it there, it'll make you feel more confident that yes, that's the one that you want to choose. Especially because now with the Naplex, you can't go backwards. So it's not like you can think about it and come back to it later. You really have to answer it on the spot and then move on. Okay, before I start with questions or with kind of going through questions, how we'll do it, it might be similar to what Dr. Ramsey did this morning, where I'll put up a question, I'll read it out. We'll do a poll that you guys have a chance to answer it and then talk through the correct answer and maybe why some of the other ones weren't correct. But I have a question for you guys. So when I did this last year, I said, you know, if you have any questions as we go, please feel free to put them in the chat and I'll answer them as we go. And after we got several questions in, some students started to feel frustrated because it really slowed things down. And I have so many problems that, you know, we might not get through all of the problems, which is fine. I tried to make sure there were more than enough, but they felt like they would rather go through more questions than really be slowed down as we went. And so we kind of did a poll on the spot, and the overwhelming vote was not to take questions as I went, but maybe at the end to save some time and, you know, go over questions for people who have them. I want to offer you guys that option though, because I hate to say, no, I'm not going to answer your questions as we go. Oh, and I see it just popped up here. So you guys can choose if you want me to save some time at the end and maybe we spend the last, you know, little bit of the session answering questions, or if you want it to be as we go along and kind of realize that we might not get through as many questions if we stop, or as many problems if we stop for questions a lot, but the session is for you guys and I am happy to do whatever you guys would prefer. Okay, so I don't know if can everyone see the answers to the polls as they come up? Or is it just me? Stacy, do you know, is it just me that sees it?
Once I share it, everyone can see it. So now they can see it because I've shared the results.
No, okay, thank you. Okay, so I see that the majority, it's not really the vast majority, but the majority of people said to do it at the end. What I would suggest is that as we're going through, let me close this one. So as we're going through, when you have questions, just write them in the chat and be very specific about like which question it was for. And so at the end, I will go through all of those and get through as many of them as I can. All right, so we will start in on questions then. Okay, question number 1. So patient is a 41-year-old female with a past medical history of type 2 diabetes, hypertension, hyperthyroidism, and pancreatitis. She's 5'6" and weighs 210 pounds. She had blood work recently with the following results. So A1C was 8.7, triglycerides are 140, LDL is 210, HDL is 60, and vitamin D level was 20. Which of the following is the best recommendation for this patient? And so I'm gonna sorry, this is the first time I've used polling in Zoom. Did that open up the poll to everyone?
No, if you open, so next to where it says share results, Janelle, if you click on that little 3-dot ellipse and it says relaunch poll, that will clear answers and relaunch the same one for them.
Okay. So I did do that, but it's she's best answer. Let me try one more time. Polling. I'm doing it, but I'm just not sure that it's doing anything when it happens. It just brings up these old ones.
Okay, let me go ahead and try. So I'm on the old one now. When I click on it, it'll let me relaunch it for them. And so here we go.
Okay, it let me click on relaunch. It just didn't actually
Do it. Okay.
do it. I'll try again, maybe from my other computer next time and see if that works.
I think it's easier for me if it's in the pop-up where the polls is versus doing it the long way. If you can see the same thing I'm seeing. That's the other bad thing about Zoom.
I have a button for polls.
Can you see where I shared the results of their answer?
I can on one of my screens.
Okay.
Okay, so I see that the majority of you guys have picked C. I'm going to stop sharing this. Close that down. Okay, so as we go through, oops. Sorry, I got to get smoother with this. So as we go through, C is the correct answer. Looks like I had 2 different versions here, but it was 20 on the first one, rosuvastatin 20. So there's a few reasons why you would want to use a high intensity statin for patients. One of them being if their LDL is greater than 190. So that would be a category that this patient falls into. Also, if they had had clinical ASCVD, so if they had had a history of MI or stroke, you would also want to start with a high intensity statin. Of our statins on here, the choices that you guys had were these ones. Atorvastatin and rosuvastatin are the only high intensity statins. And then we have to look at the dosing. So to actually be high intensity, the atorvastatin would have had to be between 40 and 80 milligrams a day, with rosuvastatin between 20 and 40. So the only option for a high intensity statin here was the rosuvastatin. The Zetia or ezetimibe, you can sometimes add on as additional therapy if you don't lipid lowering from the statin itself. Okay, so question 2, we have the same patient, the top of the case is the same, but this time the question is, which of the following are risk factors for the development of myopathy on statin therapy? And this one is select all that apply. There we go.
There it goes.
I think I just had to do it on the other computer. And then does it end by itself after like a certain time?
You can click end poll and then it'll click share results.
Okay. I'll try to wait until I just don't see a lot of answers coming in anymore to give you guys a chance to think about it. Okay, there we go. Okay, so the correct answers here. So the things that would put people more at risk for developing myopathy would be female sex and then a vitamin D deficiency. So of the options, larger body size, actually having lower weight or lower body size would be a risk factor. Hypothyroidism can be a risk factor as well. So if someone does develop myopathy on a statin, it's a good idea to check their TSH level. Being female puts them at risk, a vitamin D deficiency puts them at risk, and then older age does. So the other ones were kind of the opposite of the risk factors. Okay, question 3, we have the same patient. Now for diabetes, she is currently taking metformin 1,000 milligrams twice a day. She has prescription insurance and she's willing to use injections if needed. Which of the following would be the best recommendation to make? Okay, I think that most people have had a chance. I'm going to share the results here. So the most common answer was B. And so here I actually have A, which is dapagliflozin. So dapagliflozin is an SGLT2 inhibitor. The dulaglutide is a GLP-1, and then we have 2 insulin options. So in this one, I can see where a lot of people might have chosen the GLP-1, especially because, you know, it does help with weight gain quite a bit. But with that history of pancreatitis, it would probably be safer not to use that one. So that's why the SGLT2 inhibitor was chosen as the best choice for this answer. In terms of the other ones, so I guess when we look at it, her A1C is 8.7, so it's not a goal. We'd probably like her A1C to be below 7. So we would like to start something else. However, insulin might not be indicated at this point. Usually, depending on the guidelines you look at, the A1C would be like above 9 or 10 when you would consider adding insulin. Also, insulin can cause weight gain. So for someone, you know, who we don't want that effect for, it might not be the best choice. Okay, so now we have the same patient, and this one is just wondering which of the following is the brand name for dapagliflozin? And we'll open it back up. Okay, I see the answers are kind of slowing down, so I will share this with you guys. By far the most common answer chosen was B, Farxiga. Okay, and that one is the brand name. So this is one that you can't really reason through. It's just, knowing brand names. Jardiance would be empagliflozin, so different SGLT2. Farxiga is dapagliflozin, Victoza is liraglutide, and then Invocan is canagliflozin. This was one coming from Canada that I had a really hard time with, was brand names, because they're different between the two countries. So if you find that you have a hard time with brand names, I would definitely suggest kind of memorizing at least the top 200. And then you might miss some of them, but at least hopefully, those are the ones that you're most likely to encounter. Okay, so new question here. Select the antimicrobial pharmacokinetic property that impacts either the dose and or the interval of a drug. And this one again is select all that apply. Okay, I feel like answers are slowing down, so I'm gonna share these with you guys. You can see that all of them were picked quite a bit. E was even picked, which wasn't one of the options. Close this down, but they all will affect pharmacokinetics, right? So if we look at bioavailability, that's how much of the drug is going to get absorbed, which will definitely change the dose that you need to choose. Volume of distribution will as well. So patients that have an altered volume of distribution, for example, if they're pregnant or have cystic fibrosis or very low body weight or something that's really going to drastically change their volume of distribution, you're going to have to think about your dosing and your interval. Metabolism absolutely can. So kind of classic for pharmacists are thinking about things like CYP interactions. Either inhibitors or inducers can have an effect, and then elimination as well, right? So if we think about renal elimination, that will certainly change either your dosing or your interval if someone isn't clearing the drug as well. And I kind of noticed, I don't see anything being posted in the chat, but as we go, feel free to put questions in there and I absolutely will come back to them. Okay. So question 6, patient is a 69-year-old male presenting to the emergency department with palpitations and a racing heart. Past medical history includes hypertension and diabetes. An ECG is performed and it shows that he is in atrial fibrillation. So blood pressure is 120/72, heart rate is 131, height is 5'11", weight is 70 kilos, serum creatinine is 0.58. The emergency room physician would like to use an IV medication to control his heart rate and or rhythm. Which of the following are available in an IV form? Okay, I see that answers are kind of slowing down here, so I'm gonna share the results with you guys. Okay, and it's a little bit mixed. So there's a lot of A and a lot of D, and then a few in there for B and C. Okay, so the ones that are available in an IV form would be the diltiazem and the amiodarone. And again, these are hard ones. They're not ones you can reason through. It's just you kind of know it or you don't. You know, as we're looking at questions though, there's tons of different questions that could have been asked with this case. And so I think as you're studying, you guys can try to prompt your own questions as well, right? So you could think about, you know, what are brand to generic names for these? You could think about which ones are rate versus rhythm control, which ones are renally eliminated, you know, what is the dosing for them? What are contraindications? You can kind of make up your own questions to probably help you as you study. Just when you look at any of these questions, there's a lot of different things that could have been asked about them. This is another good example where reading the whole case doesn't actually help you. It's really just asking like, is it available in an IV formulation? So you can save yourself a little bit of time and a little bit of thought. Okay, so same patient case here. The patient is discharged with a prescription for diltiazem, 60 milligrams orally 3 times a day. Which of the following counseling points are appropriate? And again, this one is select all that apply. I've intentionally chosen a lot of select all applies because they're a lot harder to answer. And so in this case, I think it's better for you guys to get the practice instead of just finding one right answer of actually having to know for each one. So hopefully you won't have this many select all that applies on your Naplex. Okay, people are kind of slowing down with answers, so I will share the results. Here we had almost everyone said yes for C, quite a few answers for A, and then B and D were sort of not quite half. Okay, and these would be the ones that you would want to counsel on. So avoiding grapefruit juice, you're definitely going to want to know your CYP inhibitors and inducers. Grapefruit juice is a CYP inhibitor. So if you have a drug that's a CYP substrate, it can have an interaction where it causes an increased level of the drug. We actually don't really have to worry about NSAIDs together with diltiazem. That one wouldn't necessarily be a counseling point. It can lower your heart rate and your blood pressure, absolutely. Diltiazem is one of our non-dihydropyridine calcium channel blockers, so it does have that rate slowing effect, which is what we're trying to use it for here with atrial fibrillation. And then the calcium channel blockers, probably one of their most common side effects would be peripheral edema or leg swelling. So that's definitely something you would want to counsel your patients on as well. Okay, we have our same patient as before. Which of the following is the best recommendation for stroke prevention? Relaunch the poll for you. Okay, I see that the answers coming in are kind of slowing down. So I'm going to share the results with you guys. So the majority of people chose apixaban, but there was a fair amount for aspirin and rivaroxaban as well. So let's go through this one. This one kind of had a lot of things all in one question. So when we're thinking of someone with atrial fibrillation and trying to pick our best recommendation for stroke prevention, the first thing that you would need to be able to do is to calculate how high is their stroke risk. So that's going to be calculating a CHADS-VASc score. When we look at this patient, they have hypertension, which would get them a point. They have diabetes, which would get them 1 point. And then their age is 69. So they would get 1 point for that. Had it been 75 or older, it would have been 2 points, but they would just get 1. Those are kind of the only 3 risk factors that we have listed on here, right? So as we go through the acronym, right, the C would be for congestive heart failure, which is an old term, but this patient doesn't have it. Hypertension, they have. Age, they have, or not, age over 75, we got them 2 points. Diabetes, they don't have history of a stroke that we've mentioned, which would get them 2 points. Vascular disease, so if we had said that they had had, you know, a heart attack in the past, that would have gotten them a point. Age over 65, they did have, and then female sex would be a point as well. So this patient gets a CHADS-VASc of 3, which would usually indicate full anticoagulation. So that's what would kind of knock aspirin out. And really in more recent years, aspirin has fallen out of favor as a stroke prevention or AFib. Usually it'll be kind of, you know, either not recommending stroke prevention or going to a full blood thinner. So of our other options on here that are full blood thinners, oh, that's this one. I put apixaban 5 milligrams twice a day was the best answer. The reason that I didn't choose enoxaparin, first of all, if we're thinking of them going home with that, that would not be as cost effective or easy for them to use. But it's also dosed every 24 hours. So usually it would be dosed every 12 hours unless they have poor renal function. And that would be a creatinine clearance of less than 30 mils per minute. I did put the info on here that you could have used Cockcroft Galt to calculate a creatinine clearance, but it would have come out that they would have needed it every 12 hours. Rivaroxaban can absolutely be used, but the dosing here would be the dosing we would use if someone had a VTE, so either a DVT or a PE, where they get that loading dose for the first 21 days, and then we drop off to 20 milligrams once a day. So because of those reasons, apixaban was kind of the best choice for this one. If we're thinking about reasons that we would need to use a lower dose of apixaban, we kind of want to keep those in mind as well. So if they had had age over 80 years, weight under 60 kilos, or serum creatinine over 1.5, they would need 2 of those in order to get the lower dose. So they would not have qualified for a lower dose. Okay, question number 9, we have the same patient. Now your patient is started on rivaroxaban 20 milligrams once a day. So instead of using the VTE dosing, it's just kind of the regular non-valvular AFib dosing. Which of the following counseling points should you review with this patient? And again, we're going to go select all that apply. Okay, they're kind of still trickling in, but less are coming now. So I'm going to end it and share it. Okay, so we can see that a lot of people picked B, almost everyone picked D, and then a few for the others as well. Okay, and so I would agree. I guess these ones, sorry, I put them as 1, 2, 3, 4. But when we're thinking of counseling points for rivaroxaban, it doesn't really matter if it's taken together with calcium-containing products. It wouldn't affect the absorption of it, but it definitely should be taken with food. So if you have rivaroxaban, any dose over 10 milligrams at a time should be taken with food because it's going to be absorbed better, about 30% better absorption. When you're counseling patients, usually you'll counsel them to take it with their largest meal of the day, which for most people is dinner, but if their biggest meal of the day is breakfast, that is totally fine for them to take it with breakfast every day. This one doesn't make you more sensitive to sunlight, and we should definitely talk to them about signs and symptoms of bleeding. So dark tarry stools, thinking of like a GI bleed, blood in the urine, severe nosebleeds, any of those types of signs or symptoms of bleeding. All right, question 10. Select the medication that may alter the normal flora of the GI tract leading to infection. And again, this one is select all that apply. All right, so as you guys can see, all of the questions had a lot of people vote for them, with B, clindamycin, being the most common one. I would agree with you guys. So all of these ones can alter the normal flora of the GI tract and lead to infection. So lansoprazole and pantoprazole are proton pump inhibitors. And those ones, because they're going to change the pH of the GI tract, can certainly put patients at risk for C. diff. Actually, if someone does have C. diff, one of the big recommendations is to try to get them off of their PPI. They don't have a really strong indication for it, just to prevent recurrence. And then we have clindamycin and levofloxacin, 2 antibiotics. Any of the antibiotics can put patients at risk for developing C. diff. But clindamycin and levofloxacin are 2 of the kind of worst offenders. So all of these ones would be ones that could lead to that. And I just want to say, guys, I appreciate so much. I know it's the end of a long day, and I know that you guys have had a lot of info. And on each question, like 85 to 90% of you are answering the questions and participating. So I really appreciate that you're hanging in there and you're sticking in this with me and all answering. Okay, question 11. BC is a 40-year-old woman who has hypertension and drug allergies to penicillins. Reaction is angioedema and hives. And to sulfa drugs, reaction is rash. And presents to urgent care with a dry and intensely red lesion about 5 centimeters by 5 centimeters in size, with well demarcated and raised borders on her right lower extremity. She describes having pain and burning sensation and is diagnosed with erysipelas. What is the most appropriate oral antibiotic for BC's skin and soft tissue infection? Okay, so we had a little bit of a mix here. The most common response was C, but B and D got a fair number as well. Minimize this. So if you guys are feeling like ID questions are maybe hard or aren't your favorite, I would say you're not alone. For incoming residents, it's usually the area that they feel weakest in. The best answer chosen here was clindamycin. And let me kind of go through why. So if we're thinking of a skin and soft tissue infection, such as this one, we're thinking of like normal skin flora. So in particular for this, we'd be thinking of maybe like strep that we want to cover. And the reason that clindamycin was chosen as the drug of choice, so amoxicillin, she has a pretty severe penicillin allergy, and I would not choose to re-challenge her with that. She had angioedema and hives, so it would cover the bugs, but we don't really want to use it. Cefuroxime is a cephalosporin, so similarly, it would cover what we probably need to cover, but there is a chance of cross-reaction. It's not 100%, and it's one that I would say could be considered, especially if you're going to monitor her really carefully. But if there's a better choice, I would choose that one. Clindamycin doesn't have that chance of cross-reaction, and it would cover what we need to. So that's what would make it probably the best choice here. And then vancomycin is excellent at covering gram-positive bacteria. But here's where I was saying, be careful with like small words in the question. It says, which is the most appropriate oral antibiotic? And if we give vancomycin orally, it's not absorbed. So it only works for treating things in the GI tract, like C. diff. So that was why clindamycin was chosen. All right, question 12. AB is a 65-year-old woman with a history of cirrhosis who is just admitted with severe ascites and undergoes paracentesis. AB's polymorphonuclear count is found to be 300, and she's diagnosed with spontaneous bacterial peritonitis. She started on Lasix 40 milligrams once a day and aldactone 100 milligrams once a day for the treatment of ascites. Which of the following are potential side effects of these medications? And again, it is select all that apply. Okay. I'll share the results with you guys. So almost everyone picked A and C, and then there were a few in there for D and a couple for B as well. Okay, so A, I would agree with you, is gynecomastia, and that one we would, it's a possible side effect of aldactone. I wouldn't say that it's common, but I've certainly seen a number of patients that have developed it, so it's possible. And I guess here I didn't go with like generic to brand. So Lasix would be furosemide and aldactone would be spironolactone. So sometimes there's like multiple steps in a question that you have to know brand to generic as well as other things about it. Hypertension, I wouldn't expect with either of these because they're diuretics. They tend to decrease the intravascular volume and they would tend to cause hypotension. Increased serum creatinine can certainly happen. So they can cause a little bit of acute kidney injury, again, because they're decreasing the fluid inside of the blood vessels and decreasing perfusion to the kidneys. And then peripheral edema, because they're diuretics and trying to get you to pee off more fluid, I wouldn't expect that to be a side effect. Okay, so same patient case, but now the question is, which of the following would be the best recommendation to treat this patient's spontaneous bacterial peritonitis? Okay, I'm going to share the results with you guys. So people are a little slower to answer on this one. Again, I think ID is a tricky subject. The majority of you guys picked C, but there's some votes for all of the other options as well. So the best answer here would be ciprofloxacin. If we're thinking about treating SBP or spontaneous bacterial peritonitis, common pathogens we would want to cover for would be E. coli, Klebsiella, and then maybe some strep. So amoxicillin and clindamycin probably wouldn't have good enough gram-negative coverage. And Keflex wouldn't be preferred either, or cephalexin. The dose is also low for the cephalexin, even if we were going to use it. So usually the guideline preferred agents are either ceftriaxone or ciprofloxacin. Okay, so we have the same patient with cirrhosis. The treatment for AB is effective and she recovers from her spontaneous bacterial peritonitis, but develops symptoms of hepatic encephalopathy. Place the following drug options for hepatic encephalopathy in proper order from first line to second line to third line. Okay, I'll share the results with you guys. So most people chose B, although C and D had a fair number of answers as well. Okay, so the best answer here would have been B. Lactulose is always our first line option for treating hepatic encephalopathy. So A would have been out kind of right off the bat. The next best thing to add would be rifaximin, or Xifaxan is the brand name. And just remembering that if you are using Xifaxan, it's always used together with lactulose. So even if you're starting at a second line, you would use the pair of them together. And then third line options would include either neomycin or metronidazole. And those ones are very rarely used. So that's only if you have no other options left that you would use one of those two. All right, now we have a new patient. So patient is a 57-year-old male being initiated on warfarin therapy for atrial fibrillation in the hospital. In addition to atrial fibrillation, he also suffers from seizures, GERD, and depression. Which of the following home medications are likely to interact with warfarin to increase the patient's risk of blood clot formation? And again, this one is select all that apply. The answers are still trickling in, but they're kind of slowing down. So I'm going to share what we have so far. And it's a mixed bag with the exception of St. John's wort, that everyone is worried about that answer. But everything else is pretty mixed. So let's kind of go through them together. Okay, there's a lot of interactions on this page. The key is making sure which direction it's interacting in. So we want to know which ones would increase the risk of blood clot formation. So which ones are going to decrease the levels of warfarin, which are going to decrease the INR. Amiodarone does have CYP interactions, but it's a CYP inhibitor. So if it inhibits the metabolism of a drug, it's actually going to increase the level of it. So amiodarone is going to increase the INR. So it interacts, but in the opposite direction. Simvastatin really doesn't have an interaction. It's not a CYP inhibitor or inducer. Tegretol, so there's also in this question some brand name to generic names. I guess I didn't mention that. So Pacerone is amiodarone. Tegretol is carbamazepine. And that one is a CYP inducer, right? So that one's going to decrease the levels of warfarin, and it will increase the risk of blood clot formation. So that one would be. Tagamet is cimetidine, and that one is also a CYP inhibitor. So it would act in the opposite direction and increase the INR. And then St. John's wort is an inducer. So it's also going to decrease the levels of warfarin and increase the risk of blood clot formation. I would definitely, going into your Naplex, be pretty confident with your CYP inhibitors and inducers. And then the harder part is knowing the substrates, but just trying to know as many of the common ones as you can. Okay, so it's the same patient here, but the question is now, which of the following home medications can be converted to IV while the patient is in the hospital? And then again, select all that apply. The answers are still trickling in, but they're slowing down. So I'll share it with you guys. And we can see that almost everyone picked amiodarone and almost everyone picked phenytoin, and then about half of the people picked carbamazepine. So amiodarone and phenytoin are both available in an IV formation. The other ones are not. Carbamazepine seems like it might be because a lot of the anti-epileptics are, but that isn't one of them. It's only available in oral formulations. And these kinds of questions are hard because it's kind of either that you know it or you don't. It's hard to reason through them. All right, question 17. Which of the following is an appropriate rationale for switching an ACE inhibitor to an ARB? And again, it's select all that apply. I know that select all apply are worse questions to answer, but I just think it's more helpful to have to know about each one when you're practicing. And most of you have answered. Okay, so almost everyone picked D, which was cough. And then about half of people, almost half, picked angioedema as well. And then a few stragglers for the others. So I would definitely agree about cough. If someone has a cough on an ACE, it's good to switch them to an ARB. And then angioedema is a little bit trickier. So when I kind of went through, the recommendation would have been different, I think, because there is a chance of a cross reaction. But if they have angioedema to the ACE, they'll have it to the ARB as well. But it's considered quite low, and it is considered safe to challenge them on an ARB. The other ones are certainly things that can happen with an ACE, but they also happen with an ARB. I wouldn't expect them to be any better. So hypotension, renal dysfunction, and hyperkalemia would be very similar between the two. The cough and angioedema, those ones are related to the elevated bradykinin levels, which are more prevalent with these inhibitors, which is why these two, it might actually be beneficial to use an ARB instead. All right, next question. DK is a 57-year-old male that presents to the ED with complaints of severe crushing chest pain that radiates to his back. Over the past couple of days, he has experienced increased shortness of breath. Past medical history is hypertension and GERD. Home meds are listed up there. I guess lisinopril, omeprazole, aspirin, tadalafil, omeprazole. Oh no, his last dose of tadalafil was yesterday afternoon. O2 sat is 87%, troponin is 2.7. So the question is, which agent should not be administered to DK as part of his early hospital care? Okay, so we had a majority of people answered C, nitroglycerin. A fair number also picked aspirin, and then a few for the other options as well. There we go. I also had nitroglycerin listed here. So typically, if someone is having an acute coronary syndrome, we would think of early hospital care of including MONA, so morphine, oxygen, nitrates, and aspirin. The reason that nitroglycerin was actually picked here is not because of the treatment of acute coronary syndromes, but just because of the interaction with tadalafil. So if patients are on a phosphodiesterase inhibitor for erectile dysfunction, you don't want to give them nitrates in the same window. So for tadalafil, that window would be like a 48-hour period because it can increase the risk of hypotension. Nitroglycerin is a potent vasodilator and it has a risk of hypotension, but the combination can be dangerous. The other ones, I saw a fair number of people picked aspirin, and I think it might be because he already had his aspirin this morning. However, we would like him to get 325 milligrams, and he only had 81. So kind of topping him up with that extra part of the dose would be appropriate. Oxygen would be appropriate. We want to keep his O2 sats above 90%. And then morphine to give him for chest pain would also be appropriate. And especially here where we're not going to be able to give him the nitroglycerin, the morphine might be what kind of helps him with his pain. All right, question number 19. Which of the following is or are common side effects of glucophage? And again, we'll go with select all, then apply. Okay, I'll share the answers. So here we have a lot of answers for diarrhea and a lot for lactic acidosis, and then a few for the others. So let me show you mine here. The only one that I have is diarrhea. And again, this is where like just looking at those little words makes a big difference. So it says, which of the following are common side effects? Lactic acidosis, a lot of you picked, and it absolutely is associated with metformin use, but it's a very rare side effect. So it's not a common one. Diarrhea is very common. A lot of patients will experience that. Weight gain isn't associated with metformin. It actually can have a very mild weight loss of like a couple of kilograms. And then pancreatitis is also not typically associated with metformin use. If we think about our GLP-1s or DPP-4 inhibitors, those ones can be associated with pancreatitis. All right, question 20. CJ is a 55-year-old man who was diagnosed with schizophrenia 30 years ago. Since his diagnosis, he has always been on a first-generation antipsychotic. However, over the past several months, he has started to show signs of tardive dyskinesia. CJ's treating psychiatrist feels it may be best for him to try a second-generation antipsychotic at this point. He has a history of cardiac disease, and therefore his psychiatrist would like to avoid medications that may be associated with QTc prolongation. Which of the following antipsychotics should be avoided due to the risk of QTc prolongation? Open up the poll for you. And the answers have kind of stopped trickling in, so I'll share the results. A little bit of a mixed bag here. So the majority of people picked C, ziprasidone, but then everything else had a fair number of answers as well. And so I also chose ziprasidone. Ziprasidone is Giadon, and it's of the atypical antipsychotics or the second gen ones, it's the one that has the highest risk of QTc prolongation. I kind of realized as I was reading out the question, I didn't say if it was a select all that apply or not. All antipsychotics carry some risk of QTc prolongation, but the other ones, the cariprazine, brexpiprazole, and lurasidone, carry a low risk, where the ziprasidone is a very high risk. All right, question 21. A 78-year-old male is being initiated on hormonal therapy for prostate cancer. When selecting agents for the treatment of prostate cancer, which agents should include combination with an anti-androgen to prevent the occurrence of tumor flares? Select all that apply. I'm going to end this one. People are kind of slower to answer this one, maybe just due to the subject material being a little bit less familiar. It's also a very mixed bag of which agents were chosen. So it's kind of evenly distributed between them. I will say I am by no means an oncology pharmacist. But the choices that were selected here were the Lupron Depot and the Zoladex. So those ones are both LHRH agonists, and the agonists can sometimes produce that flare. So that's when you would want to put them together with an anti-androgen. Bicalutamide itself is an anti-androgen, so you wouldn't need to do that with it, or it already is one. And then the Dagerelix is an LHRH antagonist. So that one doesn't require that combination to prevent that initial flare. All right, question 22. ZX is a 29-year-old man with no significant past medical history who was in a serious motor vehicle collision 3 weeks ago and has been in the ICU sedated on a ventilator since. He's been spiking fevers up to 103.2, producing purulent sputum, and has a white blood cell count that's trending upward. Chest x-ray shows a right lower lobe infiltrate. The team diagnoses him with pneumonia and collects a deep sputum sample and blood cultures and wishes to begin therapy. So CBC is normal. The CBC is normal. The white blood cell count is elevated. Tmax is 103.2. So he's placed on a regimen of linezolid, tobramycin, and ciprofloxacin. What are potential adverse effects associated with the drugs in this regimen? And again, we want to select all that apply. Okay, answers are slowing down. So I'll share them. So most of the answers were selected. The one that was probably selected the least was answer D. But let's go through. So it is actually all of them. And then what I would think about is like, which of those drugs are causing each of them? So autotoxicity and nephrotoxicity would be the tobramycin. Aminoglycosides are very big offenders for both of those side effects. The ciprofloxacin can cause QTc prolongation, and then linezolid can cause thrombocytopenia. And I'm not surprised, linezolid is probably the least kind of common, or people probably have the least knowledge about it. So I'm not surprised that that's the one that less people chose. Okay, patient is a 63-year-old female diagnosed with stage 3B breast cancer. Her labs today are concerning for hypercalcemia of malignancy. Which of the following treatment regimens are appropriate options for the treatment of this condition? Select all that apply. Answers are kind of slowly trickling in now. This one was very evenly spread across the board. It's also a very hard question, so I'm not surprised. It's not something that people are as familiar with the treatment of. Put up my answers here. Okay, so the two that are actually indicated for the treatment of hypercalcemia malignancy would be Zometa, which is zoledronic acid, and then Zovega, which is denosumab, and those ones are appropriate. The other two, the Prolia is also denosumab, but this brand name formulation is one that's actually only indicated for osteoporosis. And then Sensipar is cinacalcet, and that one is a calcimimetic. So it's kind of, you know, I can see why people are thinking about calcium and thinking of it, but it's used to treat hyperparathyroidism, typically in patients with CKD. Just to give you guys a sense, so last year, I think, I had one of my residents help come up with a few questions, and this was one that he helped come up with. And I thought this one was probably too hard to be a Naplex question, but he had just taken the Naplex and he felt that this one was absolutely fair game. So there are going to be some hard questions on there, I guess is my point. And you can't know everything, but anything you can know is helpful. All right, question 24. AM is a 52-year-old woman whose medications include acetaminophen, 500 milligrams 4 times a day, gabapentin, 300 milligrams 3 times a day, gemfibrozil, 600 twice a day, fluoxetine, 20 daily. At the direction of her physician, she added ibuprofen, 800 milligrams BID, and capsaicin cream 3 times a day as needed to her regimen. While putting on her contacts this morning, she experienced immediate burning pain in her eyes. She immediately took out her contacts, flushes her eyes, and calls you, her pharmacist. Which of the following is most likely causing her eye pain? I'm gonna end this one. It's pretty unanimous, voting for the capsaicin cream. And that would be the one. So the capsaicin cream is made with like peppers. And so basically you want to be very sure that after patients rub it on to the area they want it on, they're washing their hands really well. Tylenol wouldn't cause the eye pain. And then the drug interactions, these ones don't actually have drug interactions. They're just kind of there to cause uncertainty or be a distractor. All right, which of the following are prophylactic treatment options for migraine headache? And you can select all that apply. Looks like a majority of people have answered. And so the highest response rate was the topiramate, but all of the answers did get a fair number of responses. So the ones that actually can be used are the top 3. Verapamil is a calcium channel blocker, but it does have an off-label use for prevention of migraines. Topiramate and valproic acid can also be used for prevention. And then ergotamine, a bunch of people had chosen that one. It is used for the treatment of migraine headaches, but not prevention. So that's why that one wasn't selected. All right, number 26. JH is a 4-year-old patient that is brought into his pediatrician with a 36-hour of rhinorrhea, nasal congestion, cough, and mild ear pain. He does not have any concurrent purulent conjunctivitis. His current temperature is 38 degrees Celsius. He has no known drug allergies and no known past medical conditions. He has not received amoxicillin in the previous 30 days. He is 36 pounds. Which of the following would be the most appropriate option for JH? Answers are still kind of trickling in. Actually, I'll let people have a second to answer. Okay, I'm going to share the results here. They're very split between the top two, the amoxicillin and the Tylenol. So let's go through the one that I picked here. So the one selected was the acetaminophen. There were a lot of kind of distractors, I feel like, in the question, talking about amoxicillin in the past 30 days and giving you all of the info that you would want for dosing the amoxicillin. So here, if we're thinking, you know, his signs and symptoms are consistent with acute otitis media or an ear infection, then because he is over 2 years old, he's had ear pain for less than 48 hours, he just has a mild fever, watch and wait would probably be appropriate for him. And then in that time, we could use acetaminophen just for like pain and fever control, mostly for pain control. So I guess I should go back and say, why not the other one? So because we're not going to treat with antibiotics, we could kind of wait and see if it lasts for a while or it gets more severe before recommending the amoxicillin. Pseudoephedrine and diphenhydramine really have limited evidence in being helpful with ear infections. So decongestant and an antihistamine. And then levofloxacin, again, we don't really need antibiotics, but we wouldn't want to choose a fluoroquinolone in a child. Okay, question number 27. So we have a 23-year-old male diagnosed with leukemia and has just received a cycle of chemotherapy. Due to his current regimen, his white blood cells are expected to experience a significant decline. Which agent may be administered as a single dose following his chemotherapy to assist the prevention of myelosuppression? So there's a lot of kind of words in there, but to prevent myelosuppression. Give you guys a couple more seconds if you want to answer. Okay, so we've got a split here between the Neupogen and the Neulasta, which makes sense. The one for this question would be Neulasta. So I feel like Neupogen is probably more well-known. It's the filgrastim, and it absolutely can increase white blood cell count. But the thing that makes Neulasta kind of the drug of choice in this question is it says which can be administered as a single dose. So Neupogen is usually given daily, and it can often take, multiple days of therapy to get white blood cell counts up. Neulasta also increases white blood cell count, but it's pegylated, so it lasts for longer. So it's usually just given as a single dose. The Aloxi and the Amend are ones that are usually used for like chemo-induced nausea and vomiting rather than increasing white blood cell count. All right, number 28. PR is an 82-year-old woman who is status post drug-eluting stent placement following presenting with a STEMI. She has a past medical history that's significant for hypertension, dyslipidemia, and hypothyroidism. She has no known drug allergies. Which of the following is the best choice of long-term antiplatelet therapy? So her maintenance therapy. Give you guys a couple more seconds to answer. Okay. So the most common choice was to use aspirin 81 plus clopidogrel. And that was what I had as well. So she had a drug-eluting stent placed, so we would want to use dual antiplatelet therapy, which would be aspirin, and it could be with clopidogrel, or it could have been with ticagrelor. The reasons that I didn't choose some of the others, so the aspirin 325 alone or the ticagrelor alone, we wouldn't want to use like monotherapy, we want dual therapy. The ticagrelor dose is also 180 twice a day, would be too high. The reason not to use B, so ticagrelor is actually a great choice to use, but if we're using ticagrelor, the maximum dose of aspirin is 100 milligrams. So we don't have it in 100 milligrams here in the States, but for us, it would be the 81 milligrams. It's just a little bit more of a more potent antiplatelet than Plavix is, or clopidogrel. All right, question 29. Patient is a 28-year-old male presenting to clinic today with a new diagnosis of HIV and has started on Biktarvy. Which of the following medications is he receiving? Okay, I opened up the poll for you guys. And answers are kind of slowing down, so I'm going to share the results with you. All right, so vast majority picked A, B, or D, with a few for the others, still a few for E. Okay, and the one, so this is a combination product. And I also included on this slide what the mechanism of action are, but it has 3 products in it, but it does not have ritonavir. Again, these are ones that you can't really reason through, you just have to know them. I will say that I would expect that there'll be at least some questions on things like oncology or HIV. It's hard to say what the questions might be, but the combo products are becoming more and more popular or commonly used. So I could see that being something that could be asked. All right, so we still have a 28-year-old male with a new diagnosis of HIV, started on Biktarvy. His CD4 count is 36. Which agent should be initiated for primary prophylaxis of opportunistic infections? Select all that apply. This one's a hard one because it's ID and HIV all at the same time. Give you guys a couple more seconds. Answers are still trickling in for this one. Okay, let me share the results. So a little bit of everything was chosen, with B, the Bactrim, being by far the most common answer. So here Bactrim was the only one that was selected. Bactrim is used for prevention of PCP pneumonia, or Uroveci. And so that one would be indicated if the CD4 is less than 200. So that one would be indicated. The azithromycin can be used to prevent MAC, or Mycobacterium avium complex. It's actually only recommended if the CD4 is less than 50, which it is, and you're delaying starting them on therapy. But here, where there's no delay in him getting his Biktarvy, it wouldn't necessarily be indicated at this point for primary prophylaxis. Fluconazole will be for treating thrush, but it's not necessarily indicated for prophylaxis. And then the valacyclovir can be used for CMV, but again, it would be indicated if you had it before, but not for prophylaxis. So I do feel like that's a fairly involved or tricky question, but those things, or any kind of component of them could certainly come up. Okay, question 31. RL is a 37-year-old man who presents to your pharmacy with a prescription for rifampin. Other medications include acetaminophen, phenytoin, warfarin, and omeprazole. Which of the following is important to counsel him on his new medication? Select all that apply. Okay. Share these results with you guys. So the first one, A, was the most commonly chosen, and then a little bit of everything else. Okay, so here are the ones that I had. So yes, this absolutely can cause body secretions to be an orange-red color, which is alarming for patients. So good to let them know. Includes like urine, tears, any body fluids. The medication can cause you to need a decrease in your warfarin. So rifampin is actually an inducer. So it's going to make you metabolize that warfarin faster. So the patient, it does interact, but it might need an increase in the dose. It can cause GI upset, and it can cause phenytoin concentrations to go down, again, because of the interaction as an inducer. Okay, I was just kind of looking at our time and we're down to the last half hour. I just wanted to take a moment to look at the questions that have been asked in the chat and the Q&A and answer those. And then we'll kind of keep going with as many of the other questions as we can get through. If we can't get through them all, I'll still flash up the answers that I had, and then you guys can look at them on your own. But I want to make sure that questions that people did ask get a chance to be answered. I'm just going to take a quick look here in the chat. The first one was, what was the CD4 count cutoff for Bactrim? That cutoff would be 200. Let's see, I'm just going to scroll back here. Do you need to know dosing of all medications? That's a loaded question. No, you probably don't need to know it for all of them, but you might need to know it for some of them, and it's impossible to know which ones. I would not expect you to need to know it for like really rare medications. So I would think that common medications, you know, if you're thinking of like Tylenol in a child, yeah, you would want to know the dosing. You know, medications that kind of have well-known maximum doses, like gabapentin, or I don't know, certain ones, it's probably helpful to know because I could see questions being asked for that, but you can't know all of the dosing for all medications. So I would just do your best and hope that you know enough of them. The next question was, in relation to spironolactone and Lasix for SBP, it was my understanding that gynecomastia was breast tissue growth in men or boys. Does this occur in women too as a result? That's a good question. So the only patients that I've really had kind of complaining of gynecomastia have always been males. I don't know in females if they would really notice it as much, to be perfectly honest. So typically, I don't know if there's a reason that it couldn't happen in women, but typically it's in men that it's reported of gynecomastia, because that's usually where it's kind of seen as a negative or unexpected side effect. The last question in the chat was for question 30. Wouldn't this patient be appropriate for the prevention of toxo, which would require DS of Bactrim? That is a good question. So yeah, because prevention for the toxo would be if it was less than 100, if the CD4 was less than 100, which would be true. And to be perfectly honest with you, I would have to double check the dosing, but I would suspect that you were probably right about that double strength. So the question was for the one that was opportunistic infections, and using Bactrim. Yes, it helps with PCP, but also for toxoplasmosis. So the dosing might need, instead of being single strength, need to be double strength. And then we have one more question that just popped in. So wouldn't immunocompromised patients need valcyclovir for CMV prophylaxis? So my understanding from looking this one up, and again, we're kind of outside of my area of expertise, but is that it wouldn't be recommended for primary prophylaxis, but if they had had it before, then yes, you would put them on valcyclovir. I'm sorry, valganciclovir. Yeah, valsite. Okay, and then someone else said only in patients with a positive CMV antibody. Now I know there's also questions in the Q&A, so I'm going to hop over to there. Okay. So the first question is, will they include statements select all that apply if there is a possibility of multiple answers? Yeah, they should, because most questions are usually going to be just like one answer, but they should say select all that apply if you can pick multiple. I would be very surprised if they didn't. I think that would be tricky. The next question on here, does history of angioedema on a RAS inhibitor exclude a patient from using other RAS inhibitors? So I'm guessing this question is asking about like aliskiren. It's used so uncommonly. I would have to double check. So I'm going to have to say that you guys would have to double check as well. The next question was, I thought there was an IV formulation of carbamazepine. I don't believe there is. It's something you could easily check in Lexicomp, but I don't believe that there is an IV formulation. I think it's just pills and oral solution. Okay, next one is for question 17. I thought that for angioedema, it would not be considered reasonable to challenge the patient with an ARB after history with an ACE. If this comes up on a Naplex, do we pick D and E? So it used to be considered not reasonable to re-challenge, but in there's been some meta-analyses and more recent literature saying that that reaction or that chance of cross-reactivity is actually very small. And so the recommendation has kind of changed to be that it is possible to re-challenge them. I would say it's always hard to say if it comes up on the Naplex, like which one do you pick? Because I'm obviously not the one writing the question. This was a question that I actually inherited from someone else that used to do this review. And they also had the same answers chosen, which were the same ones that I would have recommended, which was that you could possibly re-challenge them. So that would be my best recommendation for you, because that's the current practice. Are off-label uses for medications on the Naplex or only FDA-approved indications? That's a great question. Sometimes they can actually specifically ask, like, which of the following are, have a labeled indication or an FDA indication for something. Some medications I could see still being used if they're off-label, if they're commonly used in practice, because there are some medications that we commonly use in practice for things that technically are off-label. So depending on how they word the question, I would think it could be either. Okay, the next one is for the last set of questions. Can you give us a much shorter time period to answer them to try to make it through? Yes, I can. And then I had here, what was the CD4 cutoff for Bactrim? So for PCP prophylaxis, it would be 200. For Toxo, it would be 100. Okay, that's everything. I'm just going to double check the chat because there's a couple of things in here. Okay, I think some of these are just comments. Okay. So those ones are all comments in the chat, so you guys can see those. Okay, I'm going to keep going through questions and I will try to go quickly. We have about 20 minutes left. So I'll just kind of go very quickly so you at least get to see the answers, and I'll try to give a brief explanation. Good questions, guys. Okay, which of the following anti-anxiety meds takes 2 to 3 weeks to reach maximum efficacy? Actually, maybe what we'll do, instead of doing the polls, because we don't have a ton of time, is I'm just going to not do the polls for each one, but you can think about it and think about what you would answer, and then I'll just kind of share the answers with you. So here, the only one that it would be the Buspar. The other 3, Xanax, Librium, and Valium, are all benzodiazepines. So those ones are kind of immediate acting, whereas most of the other medications that can be used for anxiety take longer to work. Okay. Question 33. Patient is a 36-year-old male being initiated on ProAir HFA, Briolipta, Singulair for asthma. Which of the following medications included are in the inhaler formulations being initiated today? Select all that apply. So I'll still give you guys a few seconds just to kind of think through the answers. Okay, so the ones that are being started, so ProAir is albuterol, Briolipta is fluticasone, which is a steroid, and Vilanterol, which is a LABA. And then Singulair is being started, but that one is not an inhaler. So again, it's just kind of looking at what they're actually asking. That one's in tablet form. 34, for which inhaler formulation should the patient be informed to shake well prior to use? Okay, and the only one that would need to be shaken well would be the Symbicort. This one is available in an MDI. The other ones are dry powder inhalers that don't need to be. Next question. Patient is a 37-year-old female being initiated on Advair Discus for management of asthma. You are planning on counseling the patient on how to properly administer the new medication. Please place the following counseling points in the correct order. Again, I'll give you guys a second to look through it. Okay, so here would be the order. So the first one is pushing the thumb grip away until the mouthpiece is revealed, then slide the lever away from the mouthpiece until it clicks. Breathe out away from the discus. Place your mouth on the inhaler and inhale quickly and deeply, and then rinse your mouth with water and spit. Okay, and you're wanting to rinse your mouth with water to prevent thrush because of the steroid in there. RN is a 64-year-old man who's coming to the clinic to receive a 3-day chemotherapy regimen that includes cisplatin on all 3 days. He has no history of alcohol use and is otherwise healthy. He's sent home with prescriptions for lorazepam and prochlorperazine. He calls 3 days later to say that the lorazepam and prochlorperazine are not working. The nurse tells him to take the prochlorperazine every 6 hours scheduled, and calls in a prescription for ondansetron as needed. He calls back the next day saying that he is not getting any relief. Which agent would you recommend for this patient's refractory nausea and vomiting? There's a second. Okay, so the best choice here would be the olanzapine. Droperidol is only available in an IV formation, so it wouldn't be a good choice for at home. The piloncitron is a very similar kind of mechanism of action to the ondansetron. So if one's not working, there's less of a chance that the other one will as well. And then promethazine is an antihistamine, but structurally very similar to prochlorperazine. So again, there'd be less chance that the patient would get relief. So here, olanzapine, which is actually an antipsychotic medication, can be used for this chemo-induced nausea and vomiting. Question 37, which of the following is an appropriate brand name, is a brand name for the medication acetaminophen? And this one is select all that apply. Okay, here are the answers. The Tylenol, I'm sure you guys all had. C is actually the brand name for the IV Tylenol, so less commonly known. And then Motrin and Toradol are NSAIDs. They're not acetaminophen. All right, question 38. Which of the following brand names include lisinopril as an active ingredient? Again, it is select all that apply. Okay, and our answers here. So Prinavil is lisinopril, and then the Zestratic is lisinopril in combination with that should be hydrochlorothiazide. Hyzar has losartan, not lisinopril, and then Teneritic has atenolol and chlorthalidone. All right, which of the following agents may be classified as first generation antipsychotics? And again, it is select all that apply. Okay, and here it's just, I also have so in this one, there's kind of a couple of steps. There was brand to generic, and then knowing which are first generation versus second generation or atypical antipsychotics. So haloperidol is a first generation. The others are all atypical antipsychotics. Which is or are FDA approved for fibromyalgia treatment? Select all that apply. So here it is. I know there was a question about off-label indications. This one is kind of getting at that point. Okay, so the only ones with an FDA approval would be duloxetine and pregabalin. Capsaicin cream doesn't have it. Morphine or opioids don't either, and neither does ketorolac, which is an NSAID. All right, question 41. JB is started on fluticasone, MDI, 2 puffs BID, albuterol as needed, montelukast at bedtime, and loratadine. He returns 1 month later with dysphonia and was recently treated for thrush. Which medication is most likely to cause the current side effect? Okay, and the answer here would be the fluticasone. The steroids and inhalers are the reason that patients have to wash out their mouth and spit after they use them to help prevent that thrush. And they can also cause changes in the patient's voice or hoarseness. Question 42. Which of the following is a first-line treatment for acute gout? Okay, and the answer here is indomethacin. Indomethacin is an NSAID that can be used for acute gout. Other options that you could use would be steroids, especially if they're like intra-articular into the joint space, or colchicine. The reason that colchicine isn't appropriate on this list is just the dosing. So if we're going to use colchicine to treat gout, we would use 1.2 milligrams. And then you could follow that up with another 0.6 milligram dose in that first day for a maximum of 1.8. Tylenol could help a little bit with the pain, but won't treat the gout. And then allopurinol and probenecid are both agents that can lower uric acid, but they won't actually get rid of the existing uric acid or treat a gout flare. If you're thinking about duration of treatment, usually you're going to continue the medicine like indomethacin until at least like 2 or 3 days after the symptoms resolve. Okay, which of the following agents are correctly matched with common side effects? So mirtazapine causing somnolence, paroxetine causing impotence, and amitriptyline causing weight gain. I also hate these kind of questions because again, it's kind of like select all that apply. You have to really know all of the different ones for all of the combinations. Okay, oops, why did it skip over it? Oh, there we go. 1, 2, and 3. So all of them can be common side effects. And somnolence is just like sleepiness or drowsiness. Question 44. Which of the following is or are true regarding oxybutynin? And again, it is select all that apply. Okay, so it is available in an oral formulation and as a transdermal patch. Definitely anticholinergic, and then that kind of leads into the next one, which includes it causing dry eyes and dry mouth from those anticholinergic effects. However, the brand name isn't correct. So Ditropan would be the brand name for oxybutynin. Xyrem is sodium oxybate. Question 45, patient is a 54-year-old female on a DEFC for HIV. Home meds for the patient are toprolol, aspirin, Plavix, Prilosec. The patient is also being treated for community-acquired pneumonia with Levaquin daily for 5 days. Which medications are most likely to interact with the patient's HIV medication? And we're going to go with select all that apply. Okay, the most common would be the Prilosec, which is omeprazole. And that's because I also put in this question what's actually contained in a DEFC. The ripivirine needs an acidic environment for absorption. And so because PPIs kind of work around the clock, they're not a good choice. If someone was just taking like an H2RA or an antacid, you know, as long as they tried really hard to spread it out by as long as possible, like maybe 12 hours or so, that would be a better option. And then the levofloxacin can also interact just because there's multiple agents that cause QTc prolongation. Metoprolol and Plavix don't really have significant interactions. Question 46. So you're considering adding H1 or A1C monitoring services to your clinical pharmacy services, and you're evaluating a monitor to decide if it is precise and accurate to use in your clinic. Using a test solution that produces a value of 7.5% on standardized lab tests, you perform 10 sample tests on the monitor. The values you obtain with a sample monitor are, and then I have them all out there, so 7.9, 8.1, 7.9, 8, 7.9, 8, 8, 8.1, 7.9, and 8. Based on the readings, how would you evaluate this monitor? Okay, so this one is precise, but not necessarily accurate. So precise means that every time you do it, you're going to get a very similar result, which I would say is true. They're all between 7.9 and 8.1, but they're not really centered around the correct value, which was 7.5. So it's not actually accurate. And statistics questions or these type of questions, I would say like pharmacokinetic calculation questions and statistics, you can guarantee there's going to be a lot of questions. And they're really kind of, if you know how to do them and you know how to do them quickly, it's easy to guarantee yourself those points. So I would definitely focus some of your time and energy on those. It's harder with drugs because there's so many drugs that you don't know what they're going to ask about, but they're definitely going to ask about statistics. Question 47. This is a long one. RJ is a 61-year-old woman with a history of ischemic cardiomyopathy who presents to clinic with symptoms consistent with New York Heart Association class 4 heart failure. Past medical history includes hyperlipidemia, diabetes, MI, and hypothyroidism. RJ complains of progressive weight gain, about 6 pounds. Oh shoot, I thought I had actually changed some things about this question. Let me see if I did on here. So I'm sorry, because it already has the answer up, but I meant for the question to be a little bit different. And I think I forgot to put it in my previous slide. I hope that I put it in your questions that you guys have at home. So the first part was the same, but it's class 2 heart failure. Past medical history includes hyperlipidemia, diabetes, MI, and hypothyroidism. Physical exam is negative for pitting edema. And jugular venous pressure is 3 centimeters above the sternal angle. Vital signs include BP of 105/70, heart rate of 91. Lab results have a potassium of 3.6, a BUN of 39, creatinine of 1.4, which is kind of at baseline. Her current medications are levothyroxine, furosemide, lisinopril, atorvastatin, aspirin, insulin glargine, and insulin, I think that's supposed to be aspart. It just got kind of split up, 6 units before meals. So which of the following represents the next best option? And I apologize because you guys are seeing the answer before you had a chance to think about it. But the next best answer here would be to add the metoprolol succinate. So the reason to not do the other ones, metoprolol succinate has mortality benefit in heart failure patients. So we would like the patient to be on that, and their blood pressure and their heart rate would tolerate that. Metoprolol tartrate does not have that same mortality benefit, so it wouldn't be as good of a choice. Increasing lisinopril to 40, it's an okay thing to do, but the target dose is 20 to 40 milligrams a day, so we're already kind of there. So it's not as good of a choice as adding on a beta blocker. And then initiating digoxin, could be a choice as well. It does not decrease mortality, but it does decrease hospitalizations and symptoms for some patients. So I would still say that metoprolol succinate is the best choice. I think this is our last one. All right, patient is a 57-year-old male being initiated on warfarin for AFib in the hospital. In addition to AFib, he also suffers from seizures, GERD, and depression. While in the hospital, he's diagnosed with thrush and initiated on diflucan for 7 days. What changes should be made to the patient's warfarin therapy? Okay, and so the recommendation here is to decrease the dose by about 10 or 20% while on the fluconazole. So fluconazole is definitely a CYP inhibitor, so it causes, concentrations of things like warfarin to go up. You don't necessarily need to hold it completely, although I would monitor the INR more closely. You certainly don't want to increase the warfarin dose, and continuing the current, you would kind of expect that the INR is going to increase and you might end up with a supratherapeutic INR. Okay, I know that we're kind of right at time. Let me see if there are any other questions that have come in. I think in the chat, it was already answered by someone. Okay, and I think that was it. Does anyone have any last questions for the last couple of minutes? I really appreciate you guys all participating and sticking with it till the very end. As you're studying, my kind of best advice for you is just to go through common topics, common medications. If you're looking at side effects, like knowing the most common or most important, most serious ones, because you can't know absolutely everything. That's impossible. But hopefully, if you just know kind of a broad majority of things, you'll get enough of the problems correct, right? For the Naplex, you don't need 100% to pass it. So if you do have some questions where you don't know the answer, don't panic. Also, some of the problems, they're just trying to figure out if they're the right level for future tests. So there will absolutely be questions on your test that aren't actually counting towards your grade, and you have no way of knowing which ones those are. So if there's something you don't know, don't panic, just kind of try to keep a level head and keep going through it and doing your best just to carefully read the questions, make sure you're answering exactly what they're asking for. If it's a big, long case, I would look down at what are they asking for before you get too lost in the weeds on the whole case, to try to save yourself time, because it's a long test and you don't want to put too much time into the front part of it and then, run out at the end. So thank you guys so much for attending and participating. And if you do have any last minute questions, feel free to pop them into the chat. All right, thank you guys so much and good luck studying.